Alright guys, good evening. Can you all see me? Can you all hear me? Right, so can we get started? तो जैसे कि हमने बोला था, hi guys, we will continue today and we'll finish up the rest of the session. Hi Raj, hi Saif, hi Akhtar, good evening, good evening. Good evening guys. So, all geared up? I hope you're not tired. शुरू करें? Get up, get up, get up. Chalo, 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 chalo. Let's start, let's start. Okay? Hi guys, hi, good evening, good evening. So without wasting any further time, let's get it started. Okay? So until yesterday, we spoke about the peptic ulcer disease, we spoke about Boerhaave syndrome, we spoke about upper GI bleed, all that. Okay? Now, we'll be talking about few important topics in the intestine, especially about the intestinal obstruction. So in the intestinal obstruction, we have two concepts or two diseases that we'll be talking about. One is intussusception, another one is going to be volvulus, right? So as we all know, the definition of an intussusception, we call it as if the proximal loop of the intestine telescopes into a distal loop, right? So intussusception is defined as if one loop of the intestine, if one loop, usually it is the proximal loop, if one loop of intestine telescopes into another. And when you talk about this another loop, this is usually the distal loop, right? So you see, this is the proximal loop, this is the distal loop. You see the proximal loop going and getting stuck into the distal loop, and this is what we call it as intussusception. As simple as that, right? Now, the question that is asked is, in terms of intussusception, what is the most common type of intussusception in children? So most common type in children, if you ever have a doubt, remember IC in children, that is going to be ileocolic. It is going to be ileocolic. If I change the question and ask you, what is the most common type of intussusception in adults? The most common type of intussusception in adults, it is going to be colocolic. It is going to be colocolic. So the most common type of intussusception, सर इतनी देर करोगे लिखने में तो एग्ज़ाम आ जाएगा. अच्छा बेटा, तो एग्ज़ाम के बाद देख लेना, कोई टेंशन नहीं है. 9:30 से लेने वाले थे. Okay. Guys, initially we thought that we'll take it from 9:30, 10, but then your previous session got ended at 8:30, so we decided to do a bit because we'll get more amount of time, no, in that context. Okay? Chalo. So if one loop of the intestine telescopes in another is what we call as intussusception, the most common type in children is going to be ileocolic, and most common type in adult, it is going to be colocolic, right? That is with respect to intussusception. When it comes down to volvulus, volvulus is defined as if one loop of the intestine, if a loop of intestine rotates around its own axis, right? So if a loop of intestine, rotates around its own axis, if a loop of intestine rotates around its own axis, this is what we call it as volvulus. Now, when it rotates around its own axis, the vascularity to that part of the bowel is going to cut off, hence causing a lot of damage in that particular area. Okay? So if a loop of intestine rotates around its own axis, this is what we call it as volvulus. The most common site for volvulus, it is going to be the sigmoid colon. It is going to be the sigmoid colon. Now, another question is, what is the most common type that you're going to see? So when you say one type of volvulus, it is about the rotation. Will it rotate in a clockwise manner or will it rotate in an anti-clockwise manner? Remember, the most common type of volvulus is going to be an anti-clockwise rotation. It is going to be an anti-clockwise rotation. It is going to be the anti-clockwise rotation, right? So they are the important concepts with respect to the volvulus. in intussusception, one of the important aspects is about the lead point, right? It is the lead point. The concept of lead point is very, very important. What is a lead point? It is the point from where the intussusception starts. So if the intussusception begins from this particular point, no. If this is the point from where the intussusception starts, the point from where the intussusception starts is what we call it as lead point. So the lead points concept is, it is the point from where the intussusception begins. Now when you look at the lead points, couple of important questions with respect to lead points, I'm going to add it here. If they ask you, what is the most common lead point in children with age less than 1 year, the answer is going to be hypertrophied. It is your hypertrophied Peutz patches. It is the hypertrophied Peutz patches, right? If I change the question and ask you, what is the most common lead point in children overall? What is the overall most common lead point in children? The answer is going to be Meckel's diverticulum, right? The most common lead point in children causing intussusception is going to be Meckel's diverticulum. Change the question if I ask you, what is the most common lead point resulting in intussusception? But this time we are asking in adult. So in adult, it is going to be polyps. It is going to be polyps. थोड़ा सा change कर लेते हैं. If they ask you, what is the most common tumor in children causing intussusception? What is the most common tumor in children causing intussusception? The most common tumor in children causing intussusception is the small intestinal lymphoma. It is the small intestinal lymphoma. Kajal, you're bang on, absolutely correct. So अगर एग्जाम को ट्रिकी करना है, यही फालतू के सवाल बार बार पूछे जाएंगे, बट अगेन दे हैव देयर रेलेवेंस. तो एक बच्चा अगर लेस देन 1 year old है, 1 year old में hypertrophied Peutz patches क्यों बनते हैं? It is because of most common cause of diarrhea in a child less than 1 year is rotavirus. Post rotavirus infection will cause hypertrophied Peutz patches, and these hypertrophied Peutz patches will result in intussusception. It is an intussusception. Okay? Now, whenever a baby comes to you with intussusception, you have multiple investigations that you can do. One I have given you right now. This is in terms of the contrast, that is a barium enema. So when you perform a barium enema in a child with intussusception, you're going to get claw sign. You're going to get the claw sign, right? You're going to get in claw sign. But if I ask you, what is the investigation of choice of intussusception in children, please do not mark this wrong. In children, it is going to be ultrasound, and in the ultrasound, the finding that we are going to get, number one, you will get something called as the target sign. You will see a target sign, and number two, you will get something called as the pseudo kidney sign. You have the pseudo kidney sign. So this is the investigation of choice in children. This is the investigation of choice in children, right? Now, on the other hand, if I say what is the investigation of choice in adults, adults it's a very simple concept. If you are suspecting intestinal obstruction in adults, the answer is going to be CCT abdomen. It is going to be CCT abdomen, right? So it's a very, very simple concept. Adult में अगर intussusception, चाहे कोई भी cause हो, any cause of obstruction, if a patient lands up with intestinal obstruction, if the patient is an adult, it is to be done with CCT. There is no if and but beyond that particular point. Okay? On the other hand, when you look at the volvulus, when you talk about it, in the volvulus, if you look at the X-ray finding, the basic X-ray finding in a volvulus would be of a coffee bean sign. It is going to be a coffee bean sign. Now, there are two types of volvulus. I don't want to overburden you with information, but if you take this as a representation of the abdomen, so this is the representation of the abdomen. If you look at the orientation, you would see that this is how the esophagus will land up. This is how the stomach will go across. This is the small intestine. It continues across here. Let's say from here, it is going to have the appendix. This is the cecum. This is the ascending colon, the transverse colon, the descending colon, and the sigmoid colon. This is where you're talking about, right? If there is a volvulus that is occurring at the level of sigmoid colon, you see it is going to rotate like this, right? You see this is going to rotate in this particular fashion, and this is where your rectum and the anal canal is, right? So if you look at the orientation in which it is rotating, You see, this is how it is rotating, and this is the orientation that you have, right? So this is the orientation of the volvulus. Just for the sake of understanding, I'm just going to highlight it. If the sigmoid colon is going to rotate, if the sigmoid colon is going to rotate, the axis of the rotation would be something like this, right? Now, why I'm telling you very specifically is you can see in the sigmoid volvulus, if it rotates, it is going to point, the coffee bean will point towards the right upper abdomen. But if there is a cecal volvulus, you would see the orientation would be in this particular manner. So if it is going to be in the left upper abdomen, if the coffee bean is pointing towards the left upper abdomen, it is the ileocecocolic volvulus, that is called as cecal volvulus. But if it is pointing towards the right upper abdomen, it is going to be your sigmoid volvulus. Now, if I erase this, now you'll be able to see the orientation of the coffee bean. Now, does it make sense? Absolutely. You can see that the coffee bean is now pointing toward the right upper abdomen. So I know its origin is going to be sigmoid volvulus. So based upon looking at the coffee bean itself, I can tell you whether it is a sigmoid volvulus or a cecal volvulus. Okay? Absolutely correct. Clear? Chalo. So this is on the basis of X-ray. But if I say what is the investigation of choice, no doubt about investigation of choice for volvulus, it is going to be your CECT abdomen. This is going to be your CECT abdomen, right? What are the other things that you can see? As you can see in the ultrasound, you can have tong, tong, tong. This is what we call it as the target sign, right? So on an ultrasound, this is how you will see the target sign. And if you see on a lateral cut, it looks like a pseudo kidney appearance. So this is your pseudo kidney sign. This is your pseudo kidney sign. Now, if you do a contrast imaging, for the volvulus, this looks as if a bird is waiting to catch its prey. And this is what we call it as the bird of prey sign. This is what we call it as the bird of prey sign, as if the bird is waiting. Now, if you look at the coffee bean here, you see the coffee bean's orientation is like this. So if you look at the coffee bean's orientation, which is presenting here, so this is pointing towards what? It is pointing towards the left upper abdomen. If it is pointing towards the left upper abdomen, this is what we call it as the cecal volvulus. Now remember, cecal volvulus is actually a misnomer. It's a combination of three structures that is called as the ileocecocolic volvulus. Because you look at the cecum, no, it is only 7 centimeters long, right? So it is such a small segment that it cannot afford, or it cannot per se rotate around its own axis. So when it rotates, no, it takes a little bit of the terminal ileum, a little bit of the ascending colon. So it is called as ileocecocolic volvulus. So cecal volvulus per se is actually a misnomer. Okay? Now, these are in terms of the component that is present. Now, when you look at the management protocols, no, the management for an intussusception. Now, you look if you are managing a child or if you are managing an adult, right? If you are managing a child with intussusception, the first step, it is trying to resolve by enema. So, the first step in a child is to give the enema. We will start with air and then we will reach down to barium. So, initially, there are 2 attempts of air enema. If it does not resolve, I am going to resort to barium enema. If it still fails, then I'll take the patient for exploratory laparotomy. Now, when you do an exploratory laparotomy, you are going to resolve the intussusception. So, you are going to resolve it. So, once the intussusception is resolved, I would say that whether the intussuscepting part, so there are 2 parts, no, Achha, this is also important, the part of the bowel that goes in and the one that is accommodating, right? There are 2 different names for these 2. The one that takes in, it is called as intussuscipiens. This is what we call it as intussuscipiens. And the part that goes in is what we call it as intussusceptum. So the part of the bowel that actually goes in. So if you look here, this is the loop of the bowel and this is going in, right? This is the loop of the bowel, this is the proximal end, it goes into the distal end. The part of the bowel that is gone in, this part is called as intussuscipiens. intersusceptum, and one that is accommodating it, this is called as intersuscipiens. So bowel which is here, it just telescopes like this. The part of the bowel which is inside this is what we call it as intersusceptum, and one that is accommodating is called as intersuscipiens. So obviously the intersusceptum is getting compressed, and compression of the intersusceptum will cause the compression of its vascularity, and this area of the bowel can get damaged, right? Now, whenever you're looking for the management in an exploratory laparotomy, once you've resolved the intersusception, I will inspect the intersusceptum. I will inspect the intersusceptum. I'll say whether there is any damage or not. That means it is viable or non-viable. We'll see whether it is viable or it is non-viable. If it is non-viable, then it is resection plus anastomosis. Now the thing gets more interesting if you get a viable one, right? You have a patient who has underwent an intersusception. Now after the intersusception, you have resolved it by exploratory laparotomy. After you have resolved it, now that part of the bowel, that intersusceptum, is still viable. So what are you going to look for? Now I'm curious, did it have a lead point or not? So we will see the status of lead point. If the lead point is present, then you have to go ahead with resection and anastomosis. If there is no lead point, if the lead point is absent, then do nothing. Resolve it and come back. That's it. Okay. So this is where your exam questions get trickier. Okay. This is where your exam question gets trickier. Lead point is the point from where the intersusception begins. That's actually a pathological point जहाँ से intersusception शुरू होता है. तो कभी भी intersusception resolve करने के बाद अगर वो part of the intersusception which is underwent, that is जो आपका intersusceptum है ना, जब आपने रिजॉल्व किया, अगर वो पार्ट नॉन वायबल है तो रिसेक्शन एनास्टोमोसिस तो कैसे भी करना, तो उससे फर्क ही नहीं पड़ता वेदर द लीड पॉइंट इज प्रेजेंट और नॉट. लेकिन अगर वायबल है, कोई गैंग्रीन नहीं है, कोई नेक्रोसिस नहीं है, कुछ नहीं है, एंड दैट पार्ट इज हेल्दी, नाउ यू हैव टू इंस्पेक्ट इट, पैल्पेट एंड सी वेदर देयर इज एनी लीड पॉइंट इज देयर और नॉट. अगर लीड पॉइंट मिला तो रिसेक्शन एनास्टोमोसिस, लीड पॉइंट नहीं है तो वापस ऐसे ही छोड़ सकते हो. कल रात की क्लास 11:55 तक ही है, रिकॉर्ड उसके बाद नहीं है. यस, आई हैव गॉटन दैट इन्फॉर्मेशन. अब आस्क द टीम टू लुक इनटू दैट, तो उसमें थोड़ा एडिशन कर देंगे. रिकॉर्डेड वर्जन होगा, विल ट्राई टू ऐड दैट. व्हाट विल डू इज, जितना भी अपना सर्जरी का लेक्चर है ना, विच इज स्प्रेड ओवर 3 सेशंस, कल सुबह एक हुआ था, रात को एक हुआ था, आज रात को एक है, तीनों मिला के एक जगह रख देंगे ताकि यू विल बी एबल टू रिवाइज इट एंड रिकॉल इट व्हेनेवर यू वांट इट. ठीक है, सो डोंट वरी अबाउट इट. सो दिस इज विथ रिस्पेक्ट टू दैट ऑफ intersusception. Adult में, whenever you're going for the management of intersusception, here I will not do any enema. So adult में directly you will go ahead with exploratory laparotomy. Adult में directly you'll go ahead with exploratory laparotomy. The same principles are followed. There is nothing is going to be changed across here. Right? Now, in terms of volvulus in the management, the first line of management is to try a colonoscopic detorsion. It is the colonoscopic detortion. It is the colonoscopic detortion. If the colonoscopic detortion fails, take the patient for exploratory laparotomy. Take the patient for exploratory laparotomy. Exploratory laparotomy करने के बाद you will do the detortion of the volvulus, right? So after doing the detortion of the volvulus, again the question arises, do you have a viable bowel or a non-viable bowel? अगर viable bowel present है, then you have to do something called as the diversion colostomy, because it is dilated to such an extent that it won't revert back immediately normal. But if you have non-viable, then you have to do something called as an emergency colostomy, which is called as the Hartmann's surgery. Hartmann's surgery is actually a temporary colostomy, so it can be reversed. It can be reversed. ठीक है? So this is the basic difference between intersusception and volvulus. हर एक point important है, especially ना आज के डेट में हमारा 4 चांद 5 सितारा वाला जो टॉपिक है, that is going to be the management and the radiological images of intersusception and volvulus. ठीक है? जब से एग्जाम बना है ना, तब से यही सवाल बार बार आता है. It is like old wine in new bottle, packaged in different ways, presented in different ways, but the answer remains the same if the concept is clear. So I hope everybody is clear with intersusception and volvulus. याद रहेगा, clear है, ठीक है? Do not goof up on that. चलो, So yeah, I've created the management here. So we'll talk about the inflammatory bowel disease. Okay. So do we not do the volvulus treatment on the basis of the patient is stable or not? But large intestinal obstructions are surgical emergencies. Okay. If there is a perforation, yes, then you have to consider as colonic perforation. वहाँ पे directly Hartmann's procedure हो जाएगा. That is a different scenario. If a patient of volvulus present to you with peritonitis, that means there's already a perforation. In those patients, emergency laparotomy, do resection of that gangrenous bowel or the necrotic bowel, and then do a Hartmann's. So anywhere, if it is emergency, non-viable, everything comes under that category, it will be a Hartmann's procedure. But if the patient is stable, right, and you're not able to detorsion, or you're not able to revert back with colonoscopy, that means अगर आप ऐसे ही छोड़ दोगे फिर तो bowel gangrenous हो जाएगा ना. तो अभी viable इसका ये मतलब नहीं है कि आगे चल के भी viable ही रहेगा, because the vascularity is going to get compromised. So in those patients, take the patient for surgery, do a detorsion. Now if you leave it, it can revert back to normal. Again it can go under detortion, और bowel भी इतना distended होगा कि उसमें ना content cannot move forward. All those problems are there. So to prevent that, you do diversion colostomy. Clear है? ठीक है? So it is bulbul cute. The name is also quite different. चलो. So again an important topic, inflammatory bowel disease. IBD आपको रंजीत सर पैथो में पढ़ाएंगे, संतोष सर मेडिसिन में पढ़ाएंगे, और मैं आपको सर्जरी में पढ़ाऊंगा. तो we will keep whatever is strictly for surgical. ठीक है? चलो. So in terms of your inflammatory bowel disease, you have two disorders. One is Crohn's disease, another one is ulcerative colitis. Even before I begin the discussion, now एक magic word याद रख लेना Crohn's के लिए. Crohn's will have a transmural involvement. Majority of the problems in Crohn's can be understood if you understand this concept of transmural. That means from the mucosa all the way to the serosa, the entire thickness of the bowel wall is involved in Crohn's disease. In ulcerative colitis, when it comes down to ulcerative colitis is limited to mucosa and submucosa. It is limited to that of mucosa and submucosa. Okay? Now, when you look at the age of presentation for both of them, actually they present as bimodal. Okay? Both IBDs, they have two wide age of presentation. One they can see in the first, that is in 20 to 30 years of life, and the second peak you would see between 50 to 60 years. So both of them almost present at a similar age group. So it becomes very difficult for us to differentiate that whether you're dealing with Crohn's disease or whether you are dealing with ulcerative colitis. Okay? Now when we talk about sex, remember Crohn's disease is more common in female when compared to males. Ulcerative colitis is more common in males when compared to females. If you talk about a specific risk factor that is going to be present with respect to Crohn's disease, it is in Crohn's, you will see it is associated with smoking. Whereas ulcerative colitis, it is an autoimmune disorder. This is an autoimmune disorder. What is protective? There's nothing protective against Crohn's, but smoking is considered to be protective for ulcerative colitis. It is ulcerative colitis. ठीक है? Now, what are the genes which are involved? Remember for Crohn, दो gene याद रखने, NOD2 and CARD15. NOD2, CARD15, there is no specific gene for that of ulcerative colitis. Now, in clinical features for both Crohn's as well as in Crohn's as well as ulcerative colitis, what is the most common site involved? Remember for Crohn's, it is your terminal ileum. And for ulcerative colitis, it is rectum, right? No point for guessing extra. What are the clinical presentation that you are going to see? Remember, Crohn's is a disease that is going to involve from the oral cavity all the way to anal canal, right? Whereas your ulcerative colitis is strictly a large intestinal disease. So if you talk about clinical features, so I'll say in Crohn's, it is going to involve from the oral cavity to anal canal. It is going to involve oral cavity to the anal canal, whereas it is only limited to large intestine. Right? Now, inflammation of the bowel, that is inflammation anywhere, will have four features: rubor, callus, dollar, tumor. ठीक है? So I cannot see redness, I cannot see the edematous part, but I can see, because of edema, there's a lot of third space loss, there's a volume which is going to present inside the bowel, so a lot of fluid gets deposited, and that fluid will present to you as diarrhea. Now, because the mucosa is getting inflamed, that mucosa can also erode, shed, and cause bleed. So it will have, you can have both hematemesis and melena, but sorry, when you talk about hematochezia, that is going to be with ulcerative colitis when compared to that of your Crohn's disease. So Crohn's will present to you with diarrhea. Along with diarrhea, it can also have melena. It can have melena, right? Remember, there is anal involvement. So the anal involvement in Crohn's can present to you with multiple discharging fistulas. Okay? Whereas in ulcerative colitis, it is usually going to present to you with diarrhea. Along with diarrhea, it can have hematochezia. Obviously, it can also be associated with melena, right? So lower GI bleed manifestations are more likely to be present in the context of your Crohn's disease. Yes, in Crohn's, you will see skip lesions. You will not have a continuous lesion, whereas rectum is going to be present, or when you talk about ulcerative colitis, it is going to have a continuous lesion. No point for guessing, right? Now, what are the important radiological features that you're going to have? The first image that you have, this narrowing, is nothing but the string sign of Cantor. It is a string sign of Cantor. That is because of multiple skip lesions and transmural involvement. When it heals, it causes fibrosis. Sir, fibrosis will result in stricture, and that structural appearance will present to you with string sign of Cantor. When you look at the ulcerative colitis, because only the mucosa and submucosa gets inflamed, repeated inflammation causes fibrosis, and that fibrosis will cause flattening of the mucosal surface, and that flattening will cause loss of hostration. When the hostration is lost, it looks like a single pipe, and that single pipe is what we call it as the lead pipe appearance. Okay? So string sign of Cantor, that is going to be in Crohn's disease. Lead pipe appearance, that is going to be seen in your ulcerative colitis. What are the other features that you have? The colonoscopic image that you have in the Crohn's disease, this is what we call it as the Cobblestone mucosa. This is what we call it as the Cobblestone mucosa. Another one that you can see here, this is what we call it as the bear claw sign. You see a bear claw sign, that means as if a bear has literally took his claw and then scraped it. It is called as the bear claw sign. Now, can anybody identify this image of the Crohn's disease? In fact, intraoperatively, if I see this, I know it is Crohn's disease. What is this? Any idea? Quick feedback. Intraoperatively, अगर ये दिख गया ना, तो मैं बोल रहा हूँ भाई ये Crohn's ही है. What is that? It is your mesenteric. It is your mesenteric fat creeping. It is your mesenteric fat creeping. Now, the next image that you can see this whitish thickening. This whitish thickening that you see, it is your stricture, and that indicates a transmural involvement. It tells you it is a transmural involvement. It is your transmural involvement, right? That is your transmural involvement. Whereas when you look across here, this is mucosal erosion. Here you can see there is mucosal erosion, and this mucosal erosion is usually a continuous lesion. You can see the entire site is involved, so it is a continuous lesion. The second image, if you look at a little bit more carefully, you would find these components, right? These are these small inflammatory polyps, and these are what we call it as pseudopolyps, right? So you will see presence of pseudopolyps. Again, presence of pseudopolyps. Presence of pseudopolyps is again a characteristic feature of your ulcerative colitis. Exam में जितने भी सवाल पूछने हैं, that is there in this particular slide. Now, if you know, understand this displayed slide that you have, your IBD per se in terms of clinical representation is covered. Don't worry at all. Okay? Now, what is the extraintestinal manifestation? You'll talk about, when you talk about the extraintestinal manifestations, you have both extraintestinal manifestation, but when you talk about the Crohn's disease, it is the erythema nodosum, which is most common. you have the erythema nodosum, and another extraintestinal manifestation is pyoderma gangrenosum. It is the pyoderma gangrenosum. When it comes down to ulcerative colitis, it is sacroiliitis. It is the sacroiliitis and primary sclerosing cholangitis. It is a primary sclerosing cholangitis, right? Now, when it comes down to Crohn's disease, it is only going to be medical management. I think that will be pretty much covered in your medicine/pharma. So it is steroids, azithromycin, and all that. It's a symptomatic management. If there is a stricture, you do only that excision of that particular stricture. Whereas in ulcerative colitis, the first line is going to be medical management. But if the medical management fails, then you have to go with surgery. And the surgery of choice, this is important. Remember, it is total proctal colectomy. That means you are removing the entire large intestine, including the rectum. So total proctal colectomy with ileoanal. J pouch is a reservoir that you create of the small intestine. So total proctal colectomy with ileoanal J pouch anastomosis. It's an J pouch anastomosis. Now, those who do not know what is the J pouch anastomosis is, this is the esophagus, this happens to be stomach, and this is the duodenum, this is the jejunum, this is the ileum. Now, when you do a total proctal colectomy, that means I have excised it completely from the terminal ileum, the entire large intestine, including the rectum. What are you left out with? You are only left out with anal canal. Now, if I go and anastomose directly this ileum into the anal canal, all the fluid, that is succus centricus, that liquid fluid that is present, because the concentration of stools in the small intestine is liquid in nature, so they're going to fill up, and the patient has to defecate multiple times in a day, which is going to compromise the quality of life. So you have to create a reservoir. So how do we create a reservoir? Is we take this loop of the intestine, we turn this around, so it is like bending, and then I'm going to create an opening at these two ends. I will close this end of the bowel, and then I'll suture these two components to create as one single reservoir. Now, as the reservoir is created, whatever stools come, they get accumulated here. And when they get accumulated, is like a reservoir, and then the patient will have urge to defecate, and when the patient have urge to defecate, they will defecate. The frequency is going to come down. The frequency is going to come down in terms of doing a ileoanal J pouch anastomosis. Yes, somebody has given me another answer. The criteria that you follow, which was recently asked in INI-CT also, that is the true love criteria for ulcerative colitis. But again, for our exam, I don't think they will be asking you anything of that spectrum. Okay? So ulcerative colitis के लिए true love criteria is followed, that is to assess the severity and the management protocols. But again, it is not important from our current standpoint. So this is all that you should know with respect to inflammatory bowel disease. So far, any questions? कोई सवाल, कोई शक? ठीक है? चलो. Moving on, we'll talk about the hereditary cancer syndrome. Again, very, very important topic. So we'll be discussing 4 important syndromes that we have. The FAP, that is familial adenomatous polyposis. So we have the FAP, that is your familial adenomatous polyposis, Gardner syndrome, Turcot syndrome, and the Peutz-Jeghers syndrome. Now, what is the pattern of inheritance that they are going to follow? Remember, all 4 of them have autosomal dominant pattern of inheritance. So all 4 of them are autosomal dominant. It is an autosomal dominant, right? So what is the gene involved? For FAP, it is your APC gene mutation. Gardner syndrome is your APC gene mutation. Turcot is also APC gene mutation. Peutz-Jeghers is going to be STK11 gene mutation. It is your STK11 gene mutation. Which chromosome is involved? Chromosome number 5, chromosome number 5, chromosome number 5. It is going to be chromosome number 19. Now, if they want to make your exam difficult, they'll ask you which chromosome, long arm or short arm. For that, you have to remember, when you talk about the chromosome 5, it is all long, Q, Q, Q. When is chromosome 19, 9 looks like P, no. So this is 19P. All of them are Q. The only one to be remembered, P, is going to be for your Peutz-Jeghers syndrome. Now, what is the criteria for calling it as an FAP? Remember, there has to be minimum 100 polyps. The criteria, there should be more than or equal to 100 polyps to call it as FAP. Now, Gardner syndrome has an extensive criteria. I hope everybody knows it, but I'll quickly give you the mnemonic here. The mnemonic to remember the criteria is what we call it as for fed. F stands for FAP, O stands for osteoma, R stands for retinal pigmented epithelium. It is a retinal pigmented epithelium. Another F stands for fibroma. There's a epidermal cyst. It's an epidermal cyst and your desmoid tumor. All these put together is what we call it as Gardner syndrome. Turcot syndrome is FAP with brain tumors. FAP with your brain tumors. Peutz-Jeghers syndrome, it is going to have an hamartomous polyp. It is going to have hamartomous polyp. And the most common site for this hamartomous polyp is going to be jejunum. And this is also associated with mucocutaneous pigmentation. This is associated with mucocutaneous pigmentation, right? So in Peutz-Jeghers syndrome, we ask you to remember 3 letters to remember all the component P, J, and H. It is a disorder which is associated with polyps and pigmentation. The most common site for polyp is jejunum and the type of polyp is hamartomous. Remember the other 3. The familial adenomatous, it says itself is adenomatous polyp. Gardner will also have adenomatous polyp. No need to tell you because it is a component with FAP. Turcot will also be having an adenomatous polyp. I hope everybody knows the maximum malignant potential that is going to be present is going to be there with the adenomatous polyp. It is going to be an adenomatous polyp. Okay? So all these are the important components with the hereditary cancer syndrome that you will be seeing in your colorectal malignancies. Okay? Now it is your time to shine and rise. Okay? So we have all these disorders. It's a quick recap of the entire GIT. I want you to go ahead with all the possible answers in a quick session. It will be a rapid fire. Let's see if you get it right more or I get it right. So it's like a competition between you and me. Okay? Are you ready? Get set, go. Our first list. Now, here we're talking about disorder. The most common site and the most common type is what you're going to look at. Sir, पीछे वाली slide दिखा दो. देख लो. ठीक है? Right, so I hope everybody is preparing well, everybody is reading well. कल जो बताया था भूलना नहीं है कि ये आखिरी 1 month will determine कि आपने कितनी मेहनत पीछे लगा रखी है. जो अभी थक गया या जो अभी हार मान गया उसके लिए मंजिल दूर है. जो अभी लगा हुआ है, I'm telling you, if you are true to your efforts till the last day of your exam, it does not matter how your preparation is. If you're true to your craft and you're true to your hard work, उस दिन एग्जाम में वही सवाल आएगा जो आपको आता है. ठीक है? अच्छा, एक और बहुत इंपॉर्टेंट बात है, बताना भूल गया. अभी ये जो फेज है ना, ये जो एग्जाम का प्रिपरेटरी फेज है, इसमें बहुत ज़्यादा फोमो भी होगा. दैट इज फियर ऑफ मिसिंग आउट. ठीक है? तो हम सबके ग्रुप में ना एक ऐसा दोस्त होगा ना जो भाग भाग के आएगा कि यार 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 पता है, बोलेगा क्या, अरे तूने ये पढ़ा क्या. ठीक है? एंड he'll ask you some random nonsense question, and the minute they are going to ask you that question, you'll be like, अरे यार ये तो पढ़ा ही नहीं मैंने, अरे यार इसको तो सब कुछ आता है, मुझे कुछ नहीं आता. और वो आपको वो सवाल बताएगा, उसका जवाब बताएगा और चला जाएगा. उसने उसको छोड़ के कुछ नहीं पढ़ा. ठीक है? तो देयर इज अ स्टैंडर्ड गोल्डन रूल. ठीक है? ऐसा कोई भी दोस्त, पहले तो उसको अवॉइड करो. ठीक है? नहीं, कुछ होते हैं कि चेप होते हैं, अवॉइड कर ही नहीं सकते. तो ऐसा दोस्त अगर आ भी गया ना, तो जैसे वो सवाल पूछेगा ना, उसका जवाब मत देना. उसको ये बोलना कि ये सवाल कतई नहीं आएगा एग्जाम में. ठीक है? तो गोल्डन रूल इज, इफ अ पर्सन इज गोइंग टू आस्क यू सच अ स्टूपिड क्वेश्चन व्हिच यू डोंट थिंक यू हैव रेड और यू डोंट हैव हर्ड अबाउट इट, then that question will never come in exam. तो बोलना भाई तो फालतू में पढ़ रहा है, ये सवाल तो आएगा ही नहीं. ठीक है? और बोलेगा तू इतना कॉन्फिडेंट कैसे बोलता है, हाँ लगी शर्त, नहीं आएगा लगा ले. तो जब उसकी वापस लगेगी ना, then he'll understand. ठीक है? Avoid all those people because that is what is going to create more fear right now. ठीक है? अपने पे भरोसा रखना. पढ़ा है, सही पढ़ा है, और जितना पढ़ा है बार बार पढ़ना है. That is the only thing that you have to remember. ठीक है? उसके सिवा कुछ नहीं. चले, चलो मूविंग ऑन. तो भाई चलो लिस्ट शुरू करते हैं. ओके. So, TOF is a tracheoesophageal fistula. What is the most common type? Everybody knows it is your type C variety, which is the most common type. ठीक है? बेटा लास्ट 15 दिन आपने एग्जाम में थ्योरी नहीं पढ़नी है. आपने क्वेश्चंस करने हैं उस टॉपिक का रेलेवेंट पॉइंट्स फटाफट देखने हैं और आगे चलना है, ठीक है। सो यू हैव टू डू क्वेश्चंस, बिकॉज जब क्वेश्चंस करोगे तभी तो आपको अभी पता चलेगा क्या स्ट्रांग है क्या वीक है। स्ट्रांग को और स्ट्रांग करने की जरूरत नहीं है, वीक को ही करना है और यही रिवाइज करना है। देखो रेस वो नहीं जीतेगा जो ज्यादा पढ़ेगा, रेस वही जीतेगा जो बार बार पढ़ेगा, वही टॉपिक एक ही टॉपिक बार। देखिए प्रोबेबिलिटी ऑफ रिपीटिंग अ सेम टॉपिक अगेन इज वेरी हाई, लेकिन अगर आप उसमें गलती कर दोगे फिर तो क्रॉस फिनिश लाइन रीच करने का बनता ही नहीं है, ठीक है। सो इन दीज 15 डेज, मैंने कल भी बताया था, एवरी सिंगल स्टूडेंट विल डू 200 क्वेश्चंस पर डे, 200 क्वेश्चन पर डे करने हैं। अभी से मिनिमम 2 जीटी देने हैं, ज्यादा मत दीजिएगा, 2 जीटी 15 दिन इस 2 हफ्ते, हफ्ते में 1 जीटी दोगे, दैट इज मोर देन इनफ, लेकिन जीटी देना है, ठीक है। 2 जीटी 200 सवाल, यार अगर 200 सवाल पर दिन करोगे ना यार, फोड़ दोगे भाई, 3000 सवाल बन जाएंगे, ठीक है। 200 सवाल पर डे इंटू 15 डेज 3000 क्वेश्चंस। अपना 300 का एग्जाम है, 300 में अगर 3000 कर रहे हो, 10 बार क्वेश्चन पेपर अभी रिवाइज कर लोगे यार, क्या ही पॉसिबिलिटी होगी कि नहीं पास होगे, 100% होगे, ठीक है। 200 क्वेश्चंस पर डे, 2 जीटीज, दैट इज गोइंग टू किल योर एग्जाम द मिनट यू गोना फ्रीकिंग नेल इट, ठीक है। तो कोई टेंशन नहीं लेने का, चले, ठीक है। कैन यू मूव ऑन? चलो 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 मूव ऑन। Atlasia cardiaca, what is the most common site? The most common site is going to be the lower 1/3 of the esophagus. Zinkus diverticulum का most common site कौन सा है? It is your cervical esophagus. Cervical esophagus में कहाँ मिलेगा आपको? Killian's triangle से मिलेगा। Killian's triangle कहाँ मिलेगा? It will be seen on left-sided posterolateral. It is the left-sided posterolateral में मिलेगा। Esophageal cancer कहाँ मिलेगा? It is the most common site is the middle 1/3, and remember the most common type of the esophageal cancer, it is going to be your squamous cell carcinoma. It is your squamous cell carcinoma. Barrett's esophagus कहाँ मिलेगा? It will be seen in lower 1/3 of the esophagus. Web of Lamar-Wilson syndrome, it is seen in upper esophagus. It is usually seen in the upper esophagus. Borhav syndrome कहाँ मिलेगा? Borhav syndrome का जो perforation है, it is seen in the lower 1/3 of the esophagus. It is also going to be a posterior perforation that you will see. Mallory-Weiss tear का tear कहाँ मिलेगा? कल ही मैंने आपको बताया था, it is seen in cardia when compared to the gastroesophageal junction. Peptic ulcer disease का most common site क्या है? First part of the duodenum. Gastric ulcer, it is going to be antrum. Antrum में precisely बोलोगे, it is going to be at the lesser curvature which is at the angularis incisura. बेटा चैट बॉक्स नहीं चल रहा है, यू आर नॉट आंसरिंग इट। मेरे साथ फटाफट फटाफट मेरे से आगे बोलना है। आपके सामने सब कुछ नजर तो आ रहा है, मैंने कुछ छुपाया भी नहीं है, ठीक है। सो यू नाउ नो व्हाट यू आर गोइंग टू टॉक अबाउट। Mallory-Weiss बोल दिया है, पेप्टिक अल्सर हो गया, गैस्ट्रिक अल्सर हो गया। इंटरसेप्शन, अगर इंटरसेप्शन अगर बच्चों में पूछोगे, इन चाइल्ड अभी बताया था, इट इज गोइंग टू बी आइलियोकोलिक। लेकिन वही क्वेश्चन अगर अडल्ट में पूछा जाएगा, अडल्ट का मोस्ट कॉमन साइट कौन सा है? कोलोकोलिक, ठीक है। Now, volvulus का most common site कौन सा है? It is going to be your sigmoid colon. If they ask you diverticulosis का most common site कौन सा है? The narrowest portion in the entire large intestine is sigmoid colon. So answer still remains a sigmoid colon. Polyps का most common site overall कहाँ पे है? It is going to be rectum. TB stricture का most common site कहाँ मिलेगा? It is going to be terminal ileum. Typhoid perforation का most common site कौन सा है? It is also going to be terminal ileum. Ulcerative colitis का most common site कौन सा है? Rectum. Crohn's disease का मोस्ट कॉमन साइट कौन सा है? टर्मिनल आइलियम. हर्शबर्ग डिजीज का मोस्ट कॉमन साइट कौन सा है? रेक्टम. इस्कीमिक कोलाइटिस का मोस्ट कॉमन साइट कौन सा है? इट इज योर स्प्लेनिक फ्लेक्चर. व्हाई स्प्लेनिक फ्लेक्चर? बिकॉज इट इज अ वाटरशेड एरिया. दी ब्लड सप्लाई टू दिस एरिया इज गोइंग टू बी क्वाइट लिमिटेड. SMA आर्टरी सिंड्रोम. When talk about SMA artery syndrome, कौन से पार्ट ऑफ द डियोडनम को कंप्रेस करेगा? इट इज गोइंग टू कंप्रेस द थर्ड पार्ट ऑफ द डियोडनम. रिमेंबर SMA आर्टरी सिंड्रोम के लिए टेक ऑफ एंगल कितना होना चाहिए? रिमेंबर द टेक ऑफ एंगल फॉर द SMA सिंड्रोम शुड बी लेस देन 20 डिग्रीज. नॉर्मल टेक ऑफ एंगल 25 to 45 डिग्रीज होता है, ठीक है। एक्यूट मिसेंट्रिक इश्कीमिया के लिए मोस्ट कॉमन साइट कौन सा है? एक्यूट मिसेंट्रिक इश्कीमिया में इफ यू वांट टू टॉक अबाउट, इट इज द मिडल कोलिक आर्टरी दैट इज गोइंग टू गेट ओक्लूडेड. It is the middle colic artery that is going to get occluded for acute mesenteric ischemia. Large intestinal malignancy में most common is going to be rectosigmoid. अगर ये ऑप्शन में नहीं है then it is rectum. If it is not there then it is going to be your sigmoid colon. Perforation in the peptic ulcer disease is going to be more common in the first part of the duodenum. Hemorrhage is going to be more common. When I say it is going, most common source for the hemorrhage, it is going to be your gastroduodenal artery. It is going to be the gastroduodenal artery. इतना याद रखना, perforation is more common in the anterior ulcers and bleeding is more common in the posteriorly located ulcers. The most common source of the bleeding in your peptic ulcer disease is your gastroduodenal artery. When talk about the fistula and ano, the most common type according to the Parkes classification, it is going to be your intersphincteric type. The most common according to the Goodsall rule. Remember कौन सा rule लगता है? Here you are going to talk about the Parkes classification. The Parkes classification will tell you about type of fistula, and the tract is given by your Goodsall rule. Hemorrhoids, most common, it is going to be your internal hemorrhoids. Internal में position याद रखना 3, 7 and 11 o'clock position. Anal cancer, most common type is going to be the squamous cell cancer, which is seen below the dentate line. It is below the dentate line. So starting all the way from the esophagus to the anal canal, all these components have been listed out. So this is more like an active recall. जब आप एक word के बारे में पढ़ोगे, you will try to recall the entire topic, and when you know that entire topic, you know where you are stuck, getting stuck. जहाँ पे stuck करोगे वहाँ जाके एक बार revise कर लेना. That's how. ठीक है. So the objective of giving this list is to have that quick componental review of your GIT. ठीक है. ये हमारा list 1 था. अब लिस्ट 2 कौन सा है? नेम्ड अल्सर्स एंड देयर साइट. ठीक है. एप्थस अल्सर्स कहाँ पे देखोगे? यू विल सी इन योर क्रोन्स डिजीज, एंड दिस इज यूजुअली सीन इन द ओरल कैविटी इनिशियली. दिस कैन बी सीन इन द एंटायर स्मॉल इंटेस्टाइन एज वेल. कैमरून्स अल्सर कहाँ मिलेगा? कल मैंने आपको बताया था, इफ यू हैड इट इज गोइंग टू बी प्रेजेंट इन द रोलिंग हायटल हर्निया. इट इज सीन इन योर रोलिंग हायटल हर्निया. Peptic ulcer disease का ulcer कहाँ मिलेगा? The most common is going to be the first part of the duodenum. Gastric ulcer अभी मैंने आपको बताया था, it is the angularis incisura. It is the angularis incisura. Duodenal ulcer is again first part of the duodenum. TB ulcer will be seen in your terminal ileum. Remember TB का जो ulcer होगा, it is going to be वो longitudinal transverse. It is going to be a transverse ulcer. It is going to be a transverse ulcer. Typhoid, it will also be seen in your terminal ileum, but this time it is going to be your longitudinal ulcer. Typhoid का जो ulcer होगा वो longitudinal ulcer होगा. That is why it will not cause stricture. Whereas when you talk about the TB ulcer, when it heals, it is going to result in stricture. Belt-shaped ulcer जो है, it is what we call it as a tubercular ulcer, that is secondary to TB. Flash-shaped ulcer is seen in Entamoeba histolytica. Flash-shaped ulcer is seen in Entamoeba histolytica, that is your amoebic colitis. Now, amoebic colitis ka most common site is going to be cecum, so don't worry about it. Serpentine ulcer is seen in necrotizing enterocolitis, that is NEC. Cobblestone mucosa is seen in your Crohn's disease. It is seen in your Crohn's disease. Solitary rectal ulcer is seen in rectal prolapse. It is seen in the condition that is rectal prolapse. Skip ulcers is again seen in your Crohn's disease. So these are different named ulcers and their locations and their importance that we have to take into consideration. ठीक है? Sorted है? Clear है? Great. चलो. List number 3, you have your GI malignancies and their chemo regimes. तो पहली malignancy esophageal cancer हो गया. इसका chemo regime is what we call it as ECF. ECF is going to be epirubicin. It is epirubicin with cisplatin. It is cisplatin with 5-fluorouracil. Carcinoma stomach will have the same, that is ECF, that is epirubicin, cisplatin, 5-fluorouracil. Small intestinal adenocarcinoma, it is going to be FOL-FOX regime. FOL stands for folinic acid. It is your folinic acid. Then F stands for 5-fluorouracil. OX stands for oxaliplatin. It is a oxaliplatin. Large intestinal adenocarcinoma can have both, that is FOL-FOX regime, or you can have FOLFOVIR. So in the FOLFOVIR, it is folinic acid, 5-fluorouracil, but this time ARI stands for irinotecan. It is your irinotecan. Rectal cancer will have same, that is Folfox and Folfoviri. So you can have the same component. Anal cancer, we're talking about the squamous cell cancer. For this, you will follow something called as the Negros regimen. Here you have 5 fluorouracil with metamycin C. With metamycin C with radiotherapy. With radiotherapy. For GIST, when you talk about, now usually for GIST, I would prefer imatinib. Now, if it is resistant to imatinib resistant GIST, you try with sunitinib. The drug of choice for imatinib resistant GIST is going to be sunitinib. For hepatocellular cancer, it is your gemcitabine based chemotherapy. Gallbladder cancer will have same, that is cisplatin with gemcitabine. It is cisplatin with gemcitabine. Cholangiocarcinoma will also have cisplatin with gemcitabine. Pancreatic ductal adenocarcinoma will have a gemcitabine based chemotherapy. Okay? So these are, yeah, sorafenib can be tried for HCC, but HCC में gemcitabine based है. उसके बाद you have transarterial chemoembolization. Here you can use sorafenib also. Achha, to be very honest, if you give me one particular answer, we'll consider this. We'll only consider sorafenib because sorafenib has approved for the stage C variety that we have. So again, I don't want to go into greater detail. Sorafenib looks more or less a better answer. It can be given with gemcitabine based chemotherapy. That is what we call a stage, no, transarterial chemoembolization. ठीक है, वहाँ पे cisplatin with gemcitabine can be added, but sorafenib is a better answer. ठीक है, चलो. So this is about the various chemo regimes that you have to follow. That is your list number 3. Now list number 4, it is going to be about our GI malignancies in the margin of resection, proximal and distal. Remember, esophageal cancer का proximal margin 10 centimeters है, distal margin 5 centimeters है. बाकी हर जगह proximal and distal will remain 5 centimeters. The one that is going to change, it is going to be in rectal cancers. In rectal cancers, the proximal margin remains 5 centimeters, but distal margin will become 2 centimeters. So the one that you have to concentrate is the proximal margin of the rectum, proximal margin of the esophagus and the distal margin of the rectum. As simple as that. Okay? So this is the margins of resection in the GI malignancies. Okay? The last list that you have, the list number 5, is the disorder and their management that you should know. For atlasia cardia, what is the surgery of choice? It is going to be the Heller's cardiomyotomy. It is the Heller's cardiomyotomy. For diffuse esophageal spasm, it is your long esophageal myotomy. It is a long esophageal myotomy. Here we are only talking about surgical management because when you talk about the first line, it is going to be medical management. Okay? The first line for atlasia cardia is medical management. When it fails, then I'll go with surgery. The same is going to be for diffuse esophageal spasm. The first line of management is going to be a medical management, but when the medical management fails, then you will resort to surgical management. For Zenker's diverticulum, we have yesterday learned that if the diverticular mouth is less than 3 centimeters, then you have to go ahead with diverticulectomy. But if it is more than 3 centimeters, then you can go ahead with endoscopic, that is Dolman surgery. So Dolman's surgery, it is to divide the septa so that you can cater to the diverticulum. Then you have esophageal cancer. For esophageal cancer, 3 surgeries that you should know. One is your Ivor-Lewis. Another one is your McKeown's. And the last one is your Oringer's. And we spoke Oringer is currently the most preferred surgery for esophageal cancer. Then your CHPS, it is your Ramsted's pyloromyotomy. It is your Ramsted's pyloromyotomy. It is your Ramsted's pyloromyotomy. Now, for perforation peritonitis, it is going to be the Graham's omental patching. It is the Graham's omental patching, right? For peptic ulcer disease, now in a peptic ulcer disease, we can talk about either the triple therapy or the quadruple therapy. Triple or the quadruple therapy. For GERD, if it is failure of medical management, if there is failure of medical management in GERD, then you will resort to the Nissen's fundoplication. It is your Nissen's fundoplication. So when you say Nissen's fundoplication, Nissen's fundoplication is a posterior, it is a posterior 360 degrees fundoplication. It is a posterior 360 degrees fundoplication. For the D1 stricture, if there is stricture in the first part of the duodenum, you have to go ahead with Heineken-Mucklitz pyloroplasty. It is the Heineken-Mucklitz pyloroplasty. The Heineken-Mucklitz pyloroplasty. For duodenal atresia, it is going to be duodenodudenostomy. It is a duodenodudenostomy. Jejunal atresia, it is your jejunostomy. It is your jejunostomy. For ulcerative colitis, surgical is going to be total proctal. It's a total proctal colectomy with ileoanal J pouch. So the ileoanal J pouch anastomosis. For diverticulosis, it is an elective sigmoid resection. It is the elective sigmoid resection. For FAP, it is same. That is your total proctal colectomy. So I'll just add the same thing here. So I don't have the energy to write the entire context. So we'll just copy paste it and bring it here. So here also it is total proctal colectomy with ileoanal J pouch anastomosis. But a Billroth is done for gastric ulcers. Billroth is done where there is a failure of medical management. Yes, Billroth 1, Billroth 2, but Billroth 2 is preferred. Okay. For rectal prolapse, you have Repstein surgery. You have Repstein surgery. You have the modified Repsteins also. Then you have Thierch wiring. Another one that you can remember is the Freichmann-Goldberg. That is the Freichmann-Goldberg surgery. Okay. Hirschsprung disease, it is going to be your pull-through surgeries. It is the pull-through surgery. That is your Duhamel surgery, Swenson, and Soas. It is the Duhamel, Swenson's as well as Soas. Hemorrhoids, you can do Milligan-Morgan surgery, which is preferred. What is the Milligan-Morgan surgery is preferred over Ferguson surgery. Right? Adenocarcinoma of the anal canal, that is going to be your, it is going to be same. That is APR, that is your abdominoperineal resection. Is going to be abdominoperineal resection. APR is your abdominoperineal resection. Okay. Lord's procedure is for anal strictures, no. It's a forefinger anal dilatation. So your anal fissures that you have, for that you do Lord's procedure. Lord's is for anal fissure. Okay. So this summarizes your entire list in the GIT. So for any questions, quick feedback. Clear hai? Okay. So all this will give you a quick active recall. When you start looking at all these terms, you know what is there to remember, and then in the back of your head you should also revise the topic. Sorted? Clear hai? Clear hai, clear hai, clear hai, clear. HSD is Hirschsprung disease. Hirschsprung disease. HSD is your Hirschsprung disease. The most common site for the Hirschsprung disease is going to be rectum. The investigational choice for Hirschsprung disease is your rectal biopsy. The most common site from where you take the rectal biopsy is going to be the valve of Houston. What is the age of presentation? At birth, the baby can present to you with non-passive meconium. In an early childhood, the baby can present to you with acute constipation. In late childhood, there will be chronic constipation. These are the features that you will have in Hirschsprung disease. Hirschsprung disease is also called as congenital megacolon because it will cause distension. You will do a pull-through surgery. There are two-stage surgeries. Stage 1 is colostomy and stage 2 is reversal of colostomy. Clear hai? Done. ठीक है? चलो. Moving on. कल किसी ने बोला था सर थोड़ा हर्निया भी बता देना, तो हम बता देंगे. चलो, a quick recap on indirect and direct inguinal hernia. Now, I have a different approach towards hernia so that it becomes more imprintive. So in order to understand hernia, you need to understand at what exactly are we looking at. Okay? So when you look at the inguinal canal, so the inguinal canal is nothing but, if you talk, this is the external oblique aponeurosis. The opening in the external oblique aponeurosis will be called as superficial inguinal ring. Now behind this you have your fascia transversalis. The defect in the fascia transversalis is what we call it as the deep inguinal ring. Okay? Now above the fascia transversalis, what do you have? Above the fascia transversalis, you're going to have peritoneum. Okay? Medially, when you look at this, on the medial side you have this muscle, that is your rectus abdominis muscle. ठीक है? तो ये rectus abdominis muscle के पीछे जा रहे हैं. So this is the rectus abdominis muscle which is present medially. इसके पीछे आपको fascia transversalis continuously मिलेगा, as well as peritoneum that is going to be present. ठीक है? As simple as that. Now just for the sake of understanding, if I have to create it to be more extensive, so this is your rectus abdominis muscle. उसका जो medial border है इस side है, lateral border is towards the inguinal canal. ठीक है? So this is your rectus abdominis muscle. ठीक है? Now, what do you have? You have the vas deferens. ठीक है? तो vas deferens जो है वो testis से आके superficial inguinal ring में enter करते हुए, sorry, it is going to go into the superficial inguinal ring. It is going to travel into the inguinal canal. It is going to exit from the deep inguinal ring, and it is going to turn immediately. It takes a hairpin loop, that is your vas deferens. Okay? There's a nerve that is going to run across here, and this is your ilioinguinal nerve that is going to travel along with this. Okay? इतना ही है आपका inguinal canal. Just for the sake of understanding, I'm going to quickly label them all. This is your external oblique aponeurosis. कि जो external oblique aponeurosis, it is getting condensed. That condensation of external oblique aponeurosis, this condensation of your external oblique aponeurosis is what we call it as the inguinal ligament. This is what we call it as the inguinal ligament. So inguinal ligament is going to attach from the anterior superior iliac spine to that of pubic tubercle. ठीक है? ये जो आपको hole नजर आ रहा है, this is your superficial inguinal ring. This is going to be your superficial inguinal ring. ठीक है? This is your vas deferens. This happens to be the ilioinguinal nerve. This happens to be the ilioinguinal nerve. ठीक है? पीछे वाला आपका fascia transversalis है. This is your fascia transversalis. Now this defect in the fascia transversalis is your deep inguinal ring. This happens to be your deep inguinal ring. ऊपर वाला जो pink वाला है, that is your peritoneum. This is your peritoneum. ठीक है? इतना ही है. ठीक है? Now there is a blood vessel that is going to travel across here, जो पीछे से आ रही है, and it goes like this. This is your inferior epigastric artery. ठीक है? ये आपकी inferior epigastric artery, which is going to turn like this, right? This is the passage of your inferior epigastric artery. This is your inferior epigastric artery. So if you understand all these structures, हमारा जो inguinal hernia है, it is quite simple for us to understand. ठीक है? Now there are two types of inguinal hernias. One is your direct, another one is indirect inguinal hernia. तो जो concept that occurs is, आपका जो indirect inguinal hernia है, that is going to arise from that of your deep inguinal, or I can say the deep inguinal ring. Whereas ये जो area है, this triangular area that you can see, if I highlight this triangular area that you're able to see, that is between the lateral border of the rectus abdominis muscle, inferior epigastric artery and the inguinal canal, this is what we call it as Hasselbalch's triangle. Hasselbalch's triangle से जो arise करेगा वो आपका direct inguinal hernia होगा. That's it. ठीक है? So the concept is very simple, that if the hernia arises from this area, it is going to be your indirect inguinal hernia. If it arises from here, it is going to be a direct inguinal hernia. As simple as that. ठीक है? Now we'll keep this particular notion in our head. ठीक है? यहाँ तक clear है? Now we will implement that into a direct and indirect inguinal hernia. तो direct और indirect inguinal hernia में same concept हम use करेंगे. This is, अब मेरे साथ बोलो, this is your external oblique aponeurosis, which is condensed to form the inguinal canal, and that the anterior surface of inguinal canal, basically the external oblique aponeurosis, the condensation inguinal canal, this is a superficial inguinal ring. ठीक है. अच्छा, इसके पीछे हमने क्या बनाया था? We had your, what is this? This is your fascia transversalis. The defect in the fascia transversalis is your deep inguinal ring, and this continues across here. Medially हमने बनाया था, क्या बनाया था? हमारा rectus abdominis muscle है. So take this as the representation of the rectus abdominis muscle. ठीक है. So this is the orientation of rectus abdominis muscle. Then we said this happens to be the peritoneum that is going to be present. ठीक है. I'm not going to use much of the structures, but then I'll keep this as your vast difference, which is going to run into the inguinal canal. ठीक है. So हमारा इतना ही था. ये आपका external oblique aponeurosis है. This external oblique aponeurosis is giving rise to superficial inguinal ring. अंदर वाला आपका fascia transversalis है. This is giving rise to deep inguinal ring, and this is continuing all across here. ठीक है. Now, what is happening in your indirect inguinal hernia? The problem occurs here. ठीक है. Now, let's say, imagine that there is, I'll use a different color so that we understand better. Let's say there's a bowel that is sitting across here. So this area, the bowel is there, and this bowel is going to exert pressure. ठीक है. ये जो bowel है यहाँ पे, क्योंकि weight की वजह से over a period of time it is exerting pressure. अब जैसे वो pressure exert करेगा, जैसे वो pressure exert करेगा, जैसे वो pressure exert करेगा, this area is going to get weakened. ठीक है. Now, as it gets weakened, what is going to happen? You will see the peritoneum will start to sink down. ठीक है. Pressure exert हो रहा है. This pressure is exerted by the bowel. So, जैसे से bowel pressure exert करेगा, you will see that this peritoneum will start to sink in here. Now, as more and more time the bowel is going to rest here, it is going to exert more and more amount of pressure. तो ये जो आपका deep inguinal ring है, it is going to get widened. ठीक है. So widening of the deep inguinal ring is under the influence of this pressure. तो ये पूरा area it is going to transform. ठीक है. This whole area it is going to get transformed. So you will now notice your deep inguinal ring that is present, which is nothing but a defect in the fascia transversalis. आप ये देखोगे ये deep inguinal ring has now become widened. इतना मोटा हो गया. अब हुआ ये, आपका जो peritoneum था, आपका जो peritoneum था, that was also forced. This peritoneum which is present here, this peritoneum was now forced to move in. That is because of this bowel that is exerting pressure. ठीक है. अब जैसे जैसे bowel इसके अंदर sink in करता रहेगा, ठीक है, you will see more and more amount of weight is going to get concentrated. और जितना weight लगेगा, so all this bowel that is present, no, this all that bowel it is loaded, and this loaded bowel is going to exert more and more pressure. और जैसे जैसे आगे pressure बढ़ता रहेगा, as more and more amount of pressure will continue to mount, what is going to happen? Now this peritoneum which is entering from your deep inguinal ring will now start to sink into the inguinal canal. तब आप देखोगे ये जो peritoneum यहाँ पे था, peritoneum धीरे धीरे करके sink किया. It has now gone into the inguinal canal. Inguinal canal से निकलते हुए, it is only 4 centimeters long. You see it is going to pop out. Now this popping of the peritoneum via the inguinal canal, एंट्री और एग्जिट पॉइंट इंपॉर्टेंट है. एंट्री डीप इंग्वाइनल रिंग से हुई है, एग्जिट आपकी सुपरफिशियल इंग्वाइनल रिंग से होगी. एंड यू सी दी थ्रू आउट इट्स जर्नी, ये पूरा कांड आपके बावल ने किया है और मोमेंटम विच इज गोइंग टू एक्सर्ट प्रेशर, एंड यू विल इवेंचुअली सी दैट दिस इज ऑल्सो गोइंग टू पॉप आउट, एंड दिस इज व्हाट वी कॉल इट एज द कंटेंट. राइट. सो यू सी ऑल दिस बावल दैट इज ट्रैवल्ड, ये जितना भी बावल इसके साथ ट्रैवल करके गया है, राइट, ऑल दैट बावल दैट इज ट्रैवल्ड इज नाउ एग्जिटेड फ्रॉम हियर. It is now exited from here. Now it is getting accumulated in this context, right? So eventually you see the bowel has popped out and it is popping along with the peritoneum. So ये जो है आपका outer sac हो गया. ठीक है. So this is your indirect inguinal hernia. तो indirect inguinal hernia, in an indirect inguinal hernia, okay, I hope you're there. Okay. So indirect inguinal hernia में entry is from here, exit is from here, as simple as that. ठीक है. So I hope everybody is clear कि indirect inguinal hernia में entry हुई यहाँ से और exit हुई वहाँ से. ठीक है. So if you look at this, this happens to be your deep inguinal ring. So we call it as DI. This is your deep inguinal ring. This is your superficial inguinal ring. ठीक है. This is your vast difference. ये आपका पेरिटोनियम था, This is going to be the bowel. This is going to be bowel, and this is your fascia transversalis. Okay. So I hope everything is clear in your indirect inguinal hernia. Okay. This is your indirect inguinal hernia. Clear? Okay. Now come back to your direct inguinal hernia. Direct inguinal hernia mein same thing hogi with a tinge of difference. So you'll see here the same thing you have, which is going to be your external oblique aponeurosis, superficial inguinal ring. This happens to be your deep inguinal ring, which is a continuation of your fascia transversalis. ये आपका fascia transversalis हो गया. Medially, you will see this is your rectus abdominis muscle. मान लीजिए this is the rectus abdominis muscle that you have. Just for the sake of orientation, this happens to be the peritoneum that is going to go across here, and here you have your inferior epigastric artery. ठीक है? Now, we all know that the direct inguinal hernia is going to arise from this Hasselbalch's triangular area. For the sake of understanding, not to have any confusion, this is your fascia transversalis. This happens to be your deep inguinal ring, which is a continuation of your fascia transversalis. So this is, sorry, not fascia transversalis, this is a peritoneum. Okay? So this happens to be the peritoneum that you're looking at. This is your deep inguinal ring. This happens to be your superficial inguinal ring. This is your inferior epigastric artery. This is your rectus abdominis muscle. Okay? Now another structure that is going to be important here is going to be your vas deferens, which is going to run across here. So this happens to be your vas deferens. This is going to be the vas deferens. Okay? Now when you look at the direct inguinal hernia, the entry point is going to be from here. So because it's an weakness, you will see the bowel is going to sit across here. Now as the bowel sits across here, in this area it is going to exert more and more amount of pressure. तो वही same phenomena, जैसे pressure बढ़ता रहेगा, what is going to happen? This area is going to get weakened. Now as this area gets weakened, it is going to exert pressure onto the fascia transversalis. So initially you will notice that the fascia transversalis is going to become weakened like this. Okay? So initially this is how the fascia transversalis will budge. It is going to be continuous with the peritoneum, and all this is happening because the bowel that is present here is going to exert pressure. Now as the bowel is exerting pressure, this area is getting pressurized. ठीक है? So पूरा bowel यहाँ बैठा हुआ है, जिसकी वजह से ये पूरा area pressurized हो रहा है. ठीक है? Now as the time goes on, the more and more amount of pressure is going to exert. तो ultimately क्या होगा? Ultimately you'll see that this entire area is now going to shift across. ठीक है? So how does it shift? You will notice because of the pressure, the fascia transversalis is now forced to pop out from the superficial inguinal ring. Now this occurs because of the bowel that is exerting pressure, but इसके साथ साथ peritoneum भी pop out करेगा. Peritoneum के साथ साथ ये जो पूरा culprit है, the whole culprit of our story is the bowel that is exerting pressure. So you will now notice that the bowel will also exit through. You will now notice that the bowel will also exit through, and this will also become a part of this. So it will become the part of the sac. This will become the part of the sac. Okay? And this is how your direct inguinal hernia is going to occur. Right? This is how your direct inguinal hernia is going to occur. Right? So this is how your direct inguinal hernia is going to occur. See? Okay? Clear? So this is the difference between the indirect inguinal hernia and the direct inguinal hernia. तो indirect inguinal hernia के entry exit यहाँ पे, direct का entry exit यहाँ पे. If you understand, every single question that is asked in your inguinal hernia is based upon this two diagrammatic representation. ठीक है? Now what are those two? Now let's look at a quick recap about what we are trying to say. What is the entry point in the indirect inguinal hernia? Entry point in the indirect inguinal hernia is your deep inguinal ring. Whereas the entry point for your direct inguinal hernia, it is going to be your Hasselbalch's triangle. It is going to be your Hasselbalch's triangle. Okay? That is on the posterior half. Exit is going to be superficial inguinal ring. यहाँ पे भी exit is going to be superficial inguinal ring. The sac here, you can see this is the sac. The sac of the indirect inguinal hernia, it is made up of peritoneum. whereas the sac of the direct inguinal hernia, so this is what we call it as sac. The sac of the direct inguinal hernia is made up of fascia transversalis. The content here can be of both bowel as well as omentum. Here also the content can be of both bowel as well as omentum. It can be of bowel as well as omentum. Now, what is the relationship of the sac and the cord? ये आपके exam questions हैं, यही आपके 4 चांद 5 सितारे वाले questions हैं. The 3 questions that are usually asked in our exam. Now, question number 1, what is the relationship of the sac and the cord? Cord और sac का relation क्या है? तो ये cord आपका vast difference हो गया, ये sac यहाँ पे हो गया, right? This is the medial end, this is the lateral end. So I can say the sac lies lateral to the cord. ठीक है? Here you can say the sac lies lateral to the cord. The sac lies lateral to the cord. When it comes here, you can see here, this is the medial end, this is the lateral end. So here the sac lies medial to the cord. In the direct inguinal hernia, I can say the sac lies medial to the cord. It lies medial to the cord. Okay? Now, 2 important context that you have to remember. Now, what is the relationship of the neck and the inferior epigastric artery? Neck is the entry point. ठीक है? Inferior epigastric artery के relation में neck का क्या role है? So if this is your inferior epigastric artery. So let's say this is your inferior epigastric artery. ठीक है? Neck is the entry point here. So neck of the indirect inguinal hernia is lateral to inferior epigastric artery. Neck here is medial to inferior epigastric artery, and that is how your radiologists tell you whether it's a direct or an indirect inguinal hernia. No. So how do you know the relationship of the neck and the inferior epigastric artery? Now remember, when you talk about the neck here, the neck is lateral. It is lateral to the inferior epigastric artery. Here the neck lies medial. It is medial to inferior epigastric artery. Neck is medial to inferior epigastric artery. Now the risk of strangulation, it is going to be more for indirect inguinal hernia and it is going to be less for direct inguinal hernia, right? The maximum risk you will see in femoral hernia, then it is indirect inguinal hernia, then it is your direct inguinal hernia. Okay? So this is how you locate every single concept of your inguinal hernias. ठीक है? इसके beyond कोई भी कुछ भी पूछ ले, कोई दिक्कत नहीं है. ठीक है? Clear है? चलो. Now moving on. When you talk about the investigation of hernia, inguinal hernias, it is purely clinical examination. Hernia is a clinical diagnosis. You do an ultrasound just to confirm it. Otherwise, the investigation choice remains as clinical. Now, open repairs के नाम याद रख लेना. Bassanis, Scholdes, Desardas, and Melanie Dance. Lichtenstein is actually, see, all these are your pure tissue repair. So, in a pure tissue repair, I am not going to use any mesh. Lichtenstein is actually a hernioplasty. Lichtenstein is a hernioplasty. It is a mesh repair. So it is what we call it as tension-free mesh repair. This is what we call it as a tension-free mesh repair. It is a tension-free mesh repair. So when you talk about the mesh, what are the ideal characteristic of the mesh? That's your exam question. So when I talk about the mesh, number 1, it should be non-absorbable. It should be non-absorbable. It should repel water, so it should be hydrophobic. It should be hydrophobic. It should have large pores, so it should be macroporous. And more importantly, it should be lightweight. In a lightweight, it should be less than 40 grams per meter square. It should be less than 40 grams per meter square. Okay? But enterocele or omentocele नाम में है ना, if the content of the hernia is bowel, it is called as enterocele. If the content of the bowel is omentum, it is called as omentocele. As simple as that. Okay? So it should be non-absorbable, it should be hydrophobic, it should be macroporous, and it should be lightweight. That should be less than 40 grams per meter square. Okay? Now you have something called as the EHS classification, that is the European Hernia Society classification, right? In that you have the first categorization that you will see whether it is whether it is going to be a lateral hernia, whether it is going to be a medial hernia or a femoral hernia. Your lateral hernias or your inguinal hernias, your medial hernias are going to be your ventral hernias, and F is your femoral hernia. Okay. Now, second one, is it a primary or a secondary hernia? Primary is direct, secondary is recurrent. Right. And the last one is based upon the defect. Remember, currently we say defect is measured as 1 finger breadth. So one defect is equal to 1.5 centimeters. One defect is equal to 1.5 centimeters, right? Now, if you have a patient who is going to have a inguinal hernia, a patient is having a inguinal hernia with 3 centimeter defect, with a 3 centimeter defect, according to European Hernia Society. Now, because it is occurring directly, it will be primary. Inguinal hernias are considered to be lateral hernias, it is lateral. And one defect is 1.5 centimeters, 3, you have 2 defects, so it is called as PL2 variety, right? It is PL2 variety. Okay, so this is according to your European Hernia Society. Okay, ये एक classification is important from our exam perspective. Now, what are the terms that were usually used? What is herniotomy? What is herniorrhaphy? What is hernioplasty? Otomy का मतलब होता है to open up the sac, right? Herniotomy is to open the sac. It is to open the sac and reduce the content. Now remember, herniotomy is done only in indirect inguinal hernia. Direct inguinal hernia mein sac should not be opened because there it is made up of fascia transversalis. What is herniorrhaphy? It is to repair the posterior wall. It is to repair and strengthen the wall, right? So basically you're doing a tissue repair. Hernioplasty, it is to use mesh to reinforce the wall. So if you're using the mesh to recreate that wall and to recreate that component or the posterior wall, this is what we call as hernioplasty. If you're only using a pure tissue repair, it is called as herniorrhaphy. As simple as that. Okay? So this is all that you should know in the context of hernia per se. Clear hai? ठीक है? Hernia में कोई doubt? Indirect inguinal hernia, IIH is your indirect inguinal hernia. This is what IIH stands for, indirect inguinal hernia. It is your indirect inguinal hernia. It is your indirect inguinal hernia. ठीक है? Mesh बताया तो है बेटा. Ideal characteristic of mesh. Mesh is this which you have put to repair that area. No, mesh लगाते. अब इस juncture पर अगर mesh क्या है पूछोगे फिर दिक्कत है. ठीक है? Clear है? Can we move on? आगे चले. Quick feedback. Quick feedback. Can we move on? Quick feedback. चले? ठीक है. चलो. Give me a second. Okay. चलो. But types of mesh used, Proline is the preferred material. So the most common material that you're going to use, for mesh, it is going to be Proline. ठीक है? इसको छोड़ के polyester mesh भी आता है, composite mesh आता है, the two different components. But just remember, the one that we have to use is Proline mesh. Polyester is there, composite mesh is there, where you have one surface with Proline, the other one is with collagen. But then they are not important from our present standpoint. ठीक है? चलो. Now coming back to liver resections, again a very very important concept. So quickly आपको liver के बारे में थोड़ा बता देते हैं. ठीक है? तो लिवर के बारे में क्या जानोगे, ठीक है। सो क्विकली लुकिंग एट द एनाटॉमिकल ओरिएंटेशन ऑफ द लिवर। देखो लिवर को हम बोलते हैं दैट इट लुक्स लाइक अ चीज केक, ठीक है। So this is how the liver is going to be depicted. If I give you a three-dimensional image of the liver, the liver would look something like this, ठीक है। Now, in this is how the liver looks like. Right in the center of the liver, liver के एकदम बीचों बीच, now there is this groove that is going to run, and this groove is what we call it as the Cantel's line. Cantel's line divides the liver into two halves, that is the left hemiliver and the right hemiliver, ठीक है। फिर आपके तीन veins which are present, this is going to be your left hepatic vein, this is your middle hepatic vein, and this happens to be your right hepatic vein. So this is how the hepatic veins are going to run. So this is how the hepatic veins are going to run, and they will divide the liver into 4 segments. So जो hepatic vein है ना, वो liver को 4 segments में divide करता है। कौन कौन से segments? If you look at the segmental orientation of the liver, so these hepatic veins, so if you look at the hepatic veins, this is your left hepatic vein, this happens to be your middle hepatic vein, this is your middle hepatic vein, and this happens to be a right hepatic vein. Now all these hepatic veins will drain into inferior vena cava. इनने liver को ना 4 segments में divide कर दिया। कौन कौन सा है? This is going to be your left lateral segment, this is your left medial segment, this is going to be your right anterior. तो अगर आप इसको इधर से देखोगे, ये आपका right anterior segment हो गया, और ये पीछे वाला right posterior segment हो गया। So if you look at this, the hepatic vein divides the liver into left जो है वो lateral medial में हो जाएगा, right जो वो anterior posterior में हो जाएगा। Which nerve damage? चलो ठीक है यार, ये भी बता देते हैं। hernia में nerve damage is important, right? So the most common nerve injury, the most common nerve injury in open hernia repair, the most common nerve injury in open inguinal hernia repair, in an open inguinal hernia repair, it is going to be your ilioinguinal nerve. It is your ilioinguinal nerve. If I change the question, what is the most common nerve trapped in mesh in a patient who has underwent an open inguinal hernia repair? It is going to be an iliohypogastric nerve. Now this iliohypogastric nerve, when it gets trapped, no, it will going to cause chronic inguinal pain called as inguinodynia, ठीक है। If I say what is the most common nerve injury, the most common nerve injury in laparoscopic hernia repair, in a laparoscopic hernia repair, especially when you talk about the transabdominal preperitoneal repair, it is the lateral cutaneous nerve of thigh. It is the lateral cutaneous nerve of thigh. It is the lateral cutaneous nerve of thigh. ठीक है। So these are the 3 important questions on nerves when you talk about the hernia repair. Clear है? Clear? Sorted? Chalo. So going back to our liver wala discussion, so this is how the liver is divided into various segments. Now these segments are now going to be divided into your, this sections, all these are sections, okay. So जितने भी हमने बात किए हैं, they are called as sections. Now these sections are divided into segments. Now that segmental division is done with the help of your portal vein. So this is the orientation of the portal vein. So this is how the portal vein is going to run into the liver. The portal vein divides into right anterior, right posterior, and then continues into left lateral and left medial. Now with this, it is divided the liver into different segments that are present, okay? So there are different segments which are present, which are now dividing the liver into following components. Now if you look at this, you see this is one section of the, or one segment of the liver, okay? You see there is another segment of the liver which is present here. Then you see there is another segment of the liver that is present here. Then you see there is another segment of the liver which is here. Then you see there is another segment of the liver which is formed here, right? So the portal vein has divided the entire liver into these small segments. So this is the functional segments of the liver which are going to be present. ठीक है? So this is how it is going to be depicted. So this is how it is going to be depicted, and let's say we'll end with this. Okay. So liver is now divided into smaller segments with the help of portal vein. So this horizontal line is a portal vein. Just for the sake of discussion, I can say that this is your right portal vein and this happens to be your left portal vein. That is your right portal vein and this is your left portal vein. Now when you look at the segments, now it is easy. This is a segment 2, this is a segment 3, this is a segment 4A, this is a segment 4B, this is a segment 5, this is segment 6, this is segment 7, this is segment 8. बस इतनी सी ही बात है. तो आपसे एग्जाम में पूछ लेंगे कि लेफ्ट हेमी लिवर में कौन कौन से सेगमेंट्स है. लेफ्ट हेमी लिवर में क्या है? 2, 3, 4A, 4B. राइट हेमी लिवर में क्या है? 5, 6, 7 and 8. Now you will say that in left lateral section, what are the segments? 2, 3. Left medial section में क्या है? 4A, 4B. Right anterior में क्या है? 5, 8. Right posterior में क्या है? 6, 7. That's it. ठीक है? So if you get this as a gist, right? That is all that you need to know with respect to your liver anatomy. If this is sorted, there is nobody who can challenge you in these sort of questions. Now, if you are well versed, इतना max to max पूछ लेगा ना, ये जो central में जो line जा रही है, ये कौन सी line है? ये हो जाएगी आपकी Cantel's line. So what does Cantel's line? It divides the liver into two halves, the left hemi liver and the right hemi liver. So ये आपका left hemi liver हो गया और ये आपका right hemi liver हो गया. Right, this is your left hemi liver and your right hemi liver. Sorted है, clear है, ठीक है. फिर अगर मैक्स टू मैक्स अगर थोड़ा बोल देगा कि सर आपने कुछ मिस कर दिया, आपने सेगमेंट 1 मिस कर दिया, हमने मिस नहीं किया है. सेगमेंट 1 आपको लिवर उल्टा करके देखने पड़ेगा. दिस इज द पोस्टीरियर सरफेस ऑफ द लिवर. So this is how the posterior surface of the liver will be visualized. और posterior surface of the liver में ना, you see this is your inferior vena cava. ये जो है ये IVC है, that is going, and then you would say that this is where you have your portal vein. ठीक है? So this is how the portal vein is going to go into the liver. So this is the IVC and this is the portal vein that is going. In between these two, no, इन दोनों के बीच में, you see that there is this part of the liver that is present. This part of the liver that is present between the IVC and the portal vein. पीछे extend कर रहा IVC और portal vein के बीचों बीच. Now this is what we call it as the segment 1 of the liver, and this is what we call it as the caudate lobe. This is what we call it as the caudate lobe. It is an independent lobe. Now caudate lobe is supplied by the right and the left portal vein. अगर ज़्यादा बोलूँगा तो आगे चल के it is going to be, you know, drained by the right and the left hepatic duct also. So ये आ जाके आपका gallbladder बन जाएगा. ठीक है? So this is how it is going to be presented. ठीक है? So this is how your caudate lobe on the posterior aspect is going to look like. If you understand this, you know your surgical anatomy of the liver. तो आपसे एग्जाम में क्या पूछेगा? आपसे एग्जाम में ये टर्मिनोलॉजी पूछ लेगा कि भाई ये बता दो कि when you are doing a liver resections, right hemi hepatectomy में what are the segments we are going to remove? We are going to remove 5, 6, 7 and 8. Left hemi hepatectomy में what are you going to remove? I'm going to remove 2, 3, 4A and 4B. राइट एंटीरियर सेक्शन, अभी तो बताया था राइट एंटीरियर सेक्शन में क्या निकाल रहे हो? राइट एंटीरियर सेक्शन 5 and 8 will go. So right anterior section segment 5 and segment 8 will be removed. Right posterior में क्या निकालोगे? We know right posterior में क्या है? पीछे क्या है? 6 and 7. So right posterior I'm going to remove segment 6 and 7. Then you say left lateral में क्या निकालोगे? Left lateral कहाँ पे गया? Left lateral ये गया ना, 2, 3 हो गया. तो left lateral I'm going to remove 2, 3. लेफ्ट मीडियल में क्या निकालोगे? अगेन कम बैक टू आवर डायग्राम. लेफ्ट मीडियल क्या है? मीडियल में 4A 4B है, तो यू आर गोइंग टू रिमूव 4A एंड 4B. राइट ट्राइसेक्शनेक्टमी का मतलब क्या है? राइट साइड से 3 सेक्शंस निकालोगे. कौन कौन से सेक्शन निकाल दोगे? राइट साइड में एक सेक्शन राइट एंटीरियर, राइट पोस्टीरियर, राइट एंटीरियर 2. इसके इमीडिएटली क्या है? लेफ्ट मीडियल. सो यू विल रिमूव द एंटायर. तो 1 सेक्शन, 2 सेक्शन, 3 सेक्शन. राइट साइड से 3 सेक्शन निकाल रहे हो. राइट ट्राइसेक्शनेक्टमी. सो राइट ट्राइसेक्शनेक्टमी में क्या क्या निकालोगे? आई विल रिमूव 5, 6, 7 एंड 8 विथ 4A एंड 4B. लेफ्ट ट्राइसेक्शनेक्टमी में उल्टा हो जाएगा ना, 2, 3, 4A 4B निकालोगे. इसके साथ साथ क्या? यू विल गेट राइट एंटीरियर. राइट एंटीरियर में क्या मिलेगा? 5 and 8. दीज आर योर नंबर्स. ठीक है? rather than trying to mug this up, अरे ये कौन सा था, वो कौन सा था, अरे दिमाग है भाई, सिंपल सा कॉन्सेप्ट है. इफ यू नो हाउ द लिवर इज बीन अरेंज्ड, देखो इट इज सर्जिकल एनाटॉमी इज लव. ठीक है, जितना प्यार आप इससे करोगे उतना ही प्यार वो आपसे करेगी, इतना सा सिंपल है. अगर आपको ये समझने आने लगा ना, एवरीथिंग इज गोइंग टू बी जस्ट इन फ्रंट ऑफ योर आईज. ठीक है, सॉर्टेड. आपके बाद लिवर एनाटॉमी, सेगमेंट, सेक्शंस, हेमी लिवर के बारे में कभी कंफ्यूजन नहीं होगा. राइट, यू विल नेवर गेट कंफ्यूज्ड if you are oriented to this part of the concept. Clear है? Sorted? ठीक है, चलो. Can we move on? कोई अगर क्वेश्चन, सवाल, डाउट है अभी पूछ लो, फिर बाद में आगे जाने का पीछे नहीं आऊंगा, पहले ही बता रहा हूँ. ठीक है, फिर मत बोलना सर आपने बताया नहीं था. क्लियर? Can we move on? Can we move on? आज तो ठंडे पड़ गए वो मतलब पहले वाली बात नहीं रही, वो जोश नहीं है. ठीक है, Cantel's line is same portal. It is not a portal fissure. Cantel's line is a groove. Portal fissure is going to be posterior to that. No. ठीक है. Pringles, अरे यार, अच्छा Pringles क्या है? Pringles में क्या है? When you do Pringles maneuver, trauma में करते हैं for controlling the bleed. If this is the liver, somebody is asking what is Pringles. यार ऐसे करके पूरा सारा लेक्चर ही बता दो. ठीक है, I don't mind, लेकिन अभी इतना टाइम नहीं है बेटा. ये आपका esophagus है, this is the stomach, and this happens to be duodenum. ठीक है, this happens to be the duodenum. ठीक है. Now, when you look at this point, you have the hepatic duct which is present. This is the gallbladder. This is the hepatic duct that is present. Hepatic duct के पीछे आपको अपना portal vein मिलेगा. ठीक है. So this is the portal vein that is running, and then you also have your hepatic artery. ठीक है. So this is where you have your hepatic artery also, which is going to run behind it. ठीक है. So you have three important structures. You have the portal vein, the hepatic artery, as well as the bile duct. ठीक है, ये lesser curvature of the stomach है. Lesser curvature of the stomach में you will see this is all the mesenteric covering that you have, the fatty covering that you have, and suddenly you'll have a small gap from here, and this is what we call it as the foramen of Winslow. ठीक है, तो all that you have to do is you will notice ये जितने भी structures आपके present है ना, all these three structures, they all are encased. They are all encased in this fibrous band. This is what we call it as the hepatoduodenal ligament. ठीक है, इसको आप बोलोगे hepatoduodenal ligament. तो hepatoduodenal ligament के अंदर ये आपका portal triad present है. ठीक है, so whenever there is a bleeding which is occurring from the liver bed, how do you control this bleed is through this small opening, that is your foramen of Winslow. Foramen of Winslow के through I am going to put a clamp. Right, I'll take a clamp and exert it from the foramen of Winslow and then clamp this entire area. So clamping of the portal triad. So we say clamping, it is the clamping portal triad through foramen of Winslow. Through foramen of Winslow. Through the foramen of Winslow is what we call it as Pringles maneuver. It is called as a Pringles maneuver. बेटा PUBG don't spam ना यार, यूरोथ्रल इंजरी यूरोलॉजी में पढ़ाएंगे ना यार, अभी तो GIT में, थोड़ा थामो. ठीक है, चलो. So this is what is a portal triad. The portal triad is combination of bile duct, portal vein as well as hepatic artery. So it is the bile duct, portal vein and hepatic artery together is what we call it as portal triad. So Pringles maneuver करोगे ये तीन structures जो हैं they are going to get clamped. ठीक है. विजू गुप्ता, बेटा कल का remaining lecture I have already told you that it was lost the last half an hour. That will be re-uploaded. ठीक है. It will be re-uploaded. Don't worry. See, problem with the YouTube is you can only have a 12 hours of recording. So we started the session in the morning 11. So रात के 11 बजे तक जो भी session है वहाँ तक recorded है YouTube में. बाकी एक घंटा जो हमने extra किया था वो YouTube पे record नहीं हुआ है. But I have a backup for that. We'll try to put it again. Don't worry about it. ठीक है. चलने आगे. ठीक है, चलो. So we'll talk about the infections in liver. Again, a quick recap. Three common infections that you'll be talking about in liver. That is going to be pyogenic liver abscess, amoebic liver abscess, as well as your hydrated cyst. Okay. So when you talk about the causative agent, you notice or you know that the pyogenic liver abscess is caused by bacteria, and the most common bacteria, it is going to be E. coli and Klebsiella. It is the E. coli and Klebsiella. Amoebic liver abscess, it is caused by Entamoeba histolytica. Hydrated cyst is caused by Echinococcus granulosus. It is caused by Echinococcus granulosus, right? So what is the mode of spread? Now, pyogenic liver abscess usually spreads via the bile duct. Amoebic liver abscess, it is going to spread via the portal vein into the liver. This hydrated cyst will also travel via the portal vein or the portal circulation into the liver per se. Now, when you talk about pyogenic liver abscess, the usual age of presentation will be seen in age above 50 years. Amoebic liver abscess seen in younger patients, it is 20 to 30 years because of fecal-oral route of contamination with poor hygiene. Hydrated cyst, even though it is infested at the earlier age, by the time it becomes symptomatic, it is going to be 40 to 50 years. Now, pyogenic liver abscess is more common in males when compared to females. Amoebic liver abscess is also more common in males when compared to females. Hydrated cyst is equally seen in males as well as females. All these disorders are more common on right hemi liver. So on the right side of the liver, you see all these three disorders are more common on right hemi liver. Now remember, your pyogenic liver abscess are usually multiple in nature, whereas your parasitic infestations will be solitary. So your amoebic liver abscess and hydrated cyst, they'll present as solitary single lesions which are going to be present. Okay. सर ऐसे और 3 या 4 दिन तक 1 घंटे का आज ठीक है बेटा. Okay. Now bacteria cannot be endemic, whereas parasites can remain as an endemic status. When you talk about clinical features, now for pyogenic liver abscess, you will have features which are pertaining to that of the inflammation. So you will have right hypochondriac pain will be there. Along with pain, it will have fever. Now pain, fever will be present. Along with that, you will see there will be presence or history of, or I can say, will be associated with obstructive jaundice. Obstructive jaundice. Amoebic liver abscess, on the other hand, will have right hypochondriac pain will be there. It will be associated with fever. There is no jaundice, but there will be history of colitis. Usually, this is asymptomatic. This is usually asymptomatic. So it's an incidental finding that you're going to see. Now, the first investigation for all these lesions are going to be ultrasound. The investigation of choice is going to be CCT. To confirm bacteria, it is going to be aspiration culture. The parasites cannot be cultured, so hence it is going to be ELISA. When you talk about the pyogenic liver abscess, it is going to be USG guided aspiration. It is an USG guided aspiration with antibiotics. Now, when it comes down to amoebic liver abscess, a very important concept is amoebic liver abscess is a misnomer. It is not a true abscess. It is actually an example of a liquefactive necrosis. So here, if you counter or if you kill the parasite, it will resolve by only getting calcification. So here, the answer is going to be start the patient on high dose metronidazole. It is a high dose metronidazole, which is going to be 700 to 1000 milligrams. That is going to be 3 times a day for 14 days. That's the protocol that we are going to follow, right? Whereas when come to your hydrated cyst, currently the management that is preferred is going to be PAIR. PAIR stands for, it is percutaneous. It is a percutaneous aspiration and instillation of scolicide lesion. Percutaneous aspiration of hydrated fluid and instillation of scolicidal agent. Installation of scolicidal agent and reaspiration. That is your PAIR therapy that you are going to take it for hydrated cyst. So when you look at the hydrated cyst, no, the outermost layer is what we call it as the pericyst, and this is derived from liver. Then you have the green one is your ectocyst. endocyst. This is the layer that is in your hydrated cyst. Innermost is the germinal layer, and this is what we call it as endocyst. The true germinal layer of the hydrated cyst. The true germinal layer of the hydrated cyst, it is the endocyst. It is the endocyst. See? So this is with respect to that of pyogenic liver abscess, amoebic liver abscess, as well as hydrated cyst. Yes, if you're talking about scolicidal agents, the scolicidal agents that are currently being preferred, number one, you can have hypertonic saline. It is the hypertonic saline. You have 10% iodine, that is povidone. Then you have 0.5% centrimide. Usually in combination of 0.05% chlorhexidine. It is 0.05% chlorhexidine, right? So all these are your scolicidal agent. So what are these? These are your scolicidal agents. Sorry? Okay. So this is all that you should know in the context of liver infections. Clear? Chalo. Okay. So we have in HCCs now the bigger question that is usually asked is a comparison between a primary HCC and a fibrolamellar variant of hepatocellular cancer. So when you look at these two in a comparative status, HCCs, you'll see more common in males when compared to females. Fibrolamellar variants are equally seen in males as well as females. The usual age of presentation will be a mean age of 55 years for HCC. Now this is seen at a mean age of 25 years. The tumor natures here, it is going to be poorly differentiated. They're poorly differentiated, they are invasive. Whereas fibrolamellar variant, they are well differentiated and they are usually confined. So they're limited, right? Only 25% of HCCs at the time of diagnosis are resectable, whereas 75% of the fibrolamellar variants are usually resectable. It is associated with liver cirrhosis. This is not associated with liver cirrhosis. The AFP is elevated. The AFP level remains normal. So here, remember, it is the B12 binding protein. It is the B12 binding protein that is elevated in the fibrolamellar variant of HCC. Association with hepatitis B is there. There is no association with hepatitis B virus. The prognosis here is going to be poor. The prognosis here is going to be good. Right? It is going to be good. Clear? So this is the comparison between the fibrolamellar variant of hepatocellular cancer and HCC. Now, another very interesting thing about the fibrolamellar variant, you will notice that when you do a CCT, when you perform the triple phase CT or a CCT, you will see presence of central stellate star-like calcification. Central stellate calcification. It is a central stellate calcification. It is a central stellate calcification. Okay? So this is with respect to that of the comparison between the HCCs and the fibrolamellar variant of HCC. Now we'll talk about pancreas. In the pancreas, again, a very important comparative component that you have is going to be cystic lesion of pancreas. Abhi recently ये आपका 4 चांद 5 सितारा हो गया ना. This is your 4 चांद and 5 सितारा वाला question. Clear? ठीक है? चलो. But not present in all. क्या बोल रहे हो भैया? Did I miss something on the chat box? Okay, fine. So let's move on. We'll talk about the cystic lesion of the pancreas. Again, an important topic. Now, when you talk about cystic lesion of the pancreas, the first one, which is the most common cystic lesion of the pancreas overall. Now, remember the most common cystic lesion of pancreas. The most common cystic lesion of pancreas is the pseudocyst of the pancreas. It is the pseudocyst of the pancreas. If I say what is the most common cystic neoplasm of the pancreas, remember the most common cystic neoplasm of pancreas. The most common cystic neoplasm of the pancreas is the mucinous cyst adenoma. It is a mucinous cyst adenoma. Okay. So when you look at the comparator data, let's quickly talk about what is to be anticipated. When we talk about the age of presentation, remember the pseudocystic of the pancreas is usually seen between 40 to 60 years. The serous adenoma will be seen between 60 to 70 years. The mucinous adenoma is seen between 50 to 60 years, and the IPMN, that is intraductal papillary mucinous neoplasm, is seen between 60 to 70 years. Okay. Now, when you talk about the sex, remember pseudocystic of the pancreas is more likely to be seen in males when compared to females. It is more commonly seen in females. See, pseudocysts can be equally seen in males and females also. You can have both, but usually it is slightly more predicted towards males. Serous adenoma is more common in females. Your mucinous adenoma is also more common in females. IPMN is equally seen in males as well as females, right? So when you look at the appearances, these are important. Pseudocysts of the pancreas, they are large, more than 6 centimeters. They are thick walled, that is more than 6 millimeters. And it usually takes more than 6 weeks after pancreatitis. So it's a large, thick walled, and usually takes more than 6 weeks for the development of the after the pancreatitis, the pseudocyst develops in this context. When you talk about the serous adenoma of the pancreas, these are multiple. These are microcyst. They present to you as a honeycomb appearance, and they have a central stellate calcification. And they do not have, when you talk about the next column that I've put, it is about the ductal communication. They do not have any ductal communication. Pseudocyst of the pancreas, no, if it is associated acute pancreatitis, no ductal communication. If it is secondary to chronic pancreatitis, it can have a ductal communication. Okay. Now, when it talks about the mucinous cyst adenoma, it is the macrocyst. This is large. It is a macrocyst. This has thick walled. And more importantly, it has got a peripheral eggshell calcification. There is this peripheral eggshell calcification. They have got a peripheral eggshell calcification, and inside this, they have this mucin crystals. So these are your mucin crystals which are going to be present. Okay? IPMN on the other hand, so they have different varieties. They are the branch IPMN. We call it as the branch duct IPMN, that is intraductal papillary mucinous neoplasm. This is your main duct IPMN. And this is your mixed IPMN. Remember, the most common variety among all this is your mixed IPMN, and this is associated with fish mouth ampulla. This is consistent with that of the fish mouth ampulla. Now, what is the most common site of the pseudocyst of the pancreas? The pseudocyst of the pancreas, when we talk about the overall most common site, it is going to be the lesser sac. It is going to be the lesser sac. Whereas serous adenoma, it is equally distributed throughout the pancreas. Right? Here, mucinous is more common in the body and the tail of the pancreas. IPMN is more common in the head of the pancreas. Right? Now, mucin stains are only present in mucinous cyst adenoma as well as IPMN. CA remains normal in pseudocyst and serous cyst, but this is elevated in the other two. Amylase level is elevated in the IPMN as well as pseudocyst of the pancreas. The amylase remains normal here. Investigation for all of them is going to be your CCT with pancreatic protocol. So here for all the other three, it is CCT. But for IPMN, it is ERCP, because you need to visualize that fish mouth ampulla and you need to see that mucin coming out. Pseudocyst of the pancreas, the surgical, initially it is going to resolve, but if it persists beyond 6 weeks, you can do a cystogastrostomy, or we can perform a cystojejunostomy. A cystogastrostomy or a cystojejunostomy can be done. Serous adenoma, we prefer doing enucleation. Mucinous adenoma, it is your distal pancreatectomy. It is a distal pancreatectomy. And IPMN, we will perform a near total pancreatectomy. We'll perform a near total pancreatectomy. We'll perform a near total pancreatectomy. Okay. Sorted. So this is all that you should know in the cystic lesion of the pancreas. Okay. Guys, I see that you guys are getting a bit lazy. Okay. You are not supposed to get lazy. You are not supposed to give up. You are not supposed to be tired. You have to put that extra effort. Tell your brain that your body is okay. Tell your brain that you can do it. You can focus it. ठीक है? तो deviate नहीं होना है. I told you yesterday also, the purpose of rapid revision is you be able to recite before I write it. मेरे लिखने से पहले आपको बोलना चाहिए. ठीक है? So don't worry about it. देखो पैनक्रियास में ना एक्यूट पैनक्रियाटिस और क्रॉनिक पैनक्रियाटिस तो पढ़ना ही पढ़ना है. ठीक है? That I am presuming that everybody would have read it. So I'm not going to go details. ये जो टेबल है यूजुअली यू मिस आउट इट और बाउंसर यहीं से आता है. ठीक है? इसी में से सूडोसिस में से सवाल आ गया, यूजुअली सिस्टिक लीजन्स में से आ गया. ठीक है? तो इट ऑल हैपेंस इन दैट पर्टिकुलर कॉन्टेक्स्ट. सो आई ट्राई टू कीप इट टू द पॉइंट. ठीक है? मैं मान के चल रहा हूँ कि आप पढ़ोगे ही पढ़ोगे. चलो, सो फ्यू इंपॉर्टेंट ट्रायड्स दैट आर यूजुअली आस्क्ड इन योर एग्जाम. तो क्विकली देख लेते हैं कौन कौन से ट्रायड है. सबसे पहला triad, it is going to be Carney's triad. The Carney's triad is seen in multifocal GIST. So you have a patient with multifocal GIST. You'll have a patient with multifocal GIST, paraganglionoma, and extraadrenal paraganglionoma, and pulmonary chondroma. Okay? So multifocal GIST, extraadrenal paraganglionoma, and pulmonary chondroma is your Carney's triad. फिर होता है Macular's triad. कल ही बात की थी Boraf syndrome में. It is going to be pain, retching, and there will be subcutaneous emphysema. फिर Bouchard's triad. The Bouchard's triad is seen in gastric volvulus. So what do you have? You have pain in terms of like a colicky abdominal pain. Retching is there but no vomiting because the stomach is twisted, and when you try to push the Ryle's tube, you cannot push it. Inability to pass Ryle's tube is what is Bouchard's triad. Then you have your Murphy's triad with appendicitis, that is going to be pain, vomiting, and fever. And remember, rebound tenderness is one of the most reliable findings that you have. Charcot's triad is seen in your cholangitis. All of them will be intermittent feature, that is pain, fever, and jaundice. All of them are intermittent, and that is your Charcot's triad. Then you have the Quincke's triad, or also called as the Salbutum triads, which is the triad for hemobilia. Pain, jaundice, and melena. Then you have the Tilloch's triad. This has been your recent exam question. That is a mesenteric cyst. So Tilloch's triad में क्या मिलेगा? You will see a mid-abdominal cystic swelling. Now this swelling will only move perpendicular to the mesenteric band attachment, not along its direction. Second thing that you will notice that one, you have the swelling, this moves only perpendicular, and there will be band of resonance. There will be dullness, that is fluid thrill will be there in the cystic wall, but a band of resonance around it, and that tells you it is a Tilloch's triad, and this is with respect to that of your mesenteric cyst. ठीक है? एग्जाम में अगर कोई भी ट्रायड बेस्ड क्वेश्चन आएगा, this is more likely that they're going to ask you, not beyond this. ठीक है? तो मोस्टली यही ट्रायड्स पूछे जाते हैं. इसमें से एक बार देखो, कभी आपको बोल देगा बोचार्ड ट्रायड क्या है, कभी बोल देगा क्विंकीज क्या है, कभी बोल देगा टिलॉक्स क्या है. यही बाउंसर्स है, बाकी सबको आपको आता ही है. ठीक है? सो यू नीड टू शार्पन योर skill, you need to sharpen your knowledge, you need to know where to emphasize, when to emphasize, कैसे करना है, क्या नहीं करना है, and this is right there in front of you. Clear है? Sorted? ठीक है? कैन वी कंटिन्यू? चलो भैया जल्दी जल्दी जल्दी. अभी स्पॉटर्स हैं. ठीक है? इस पे टाइम पास नहीं करने का. ठीक है? स्पॉटर नंबर 1 अल्ट्रासाउंड है. अगर आपको थोड़ा डेटा चाहिए तो डेटा ये मिलेगा कि ये मेरे पास 4 वीक्स ओल्ड बेबी है, 4 वीक्स ओल्ड मेल चाइल्ड मेरे पास आया है. ठीक है? दिस बेबी इज हैविंग रिकरेंट एपिसोड्स ऑफ नॉन बिलियस वॉमिटिंग. This baby is having recurrent episodes of non-bilious vomiting. I have given you the ultrasound finding. Now in the ultrasound finding, what do you see? You see there is cervix sign. It looks like a cervix. Second, it can also be called as the antral nipple sign. It can also be called as the antral nipple sign. And when you look at this particular, I'm trying to measure this length and this width. And I'm saying the length is 16 millimeters and the width is 4 millimeters. So now you know we are talking about the condition which is nothing but your congenital hypertrophic pyloric stenosis. So this is your CHPS. तो ये जो हमारा ultrasound है वो CHPS का है. We have already discussed it. What is important? What is the electrolyte imbalance that you have? The electrolyte imbalance that you will see is going to be metabolic alkylosis. Along with metabolic alkalosis, there will be hypochloremia. Along with hypochloremia, there will be hypokalemia. With that, there will be presence of paradoxical aciduria. Paradoxical aciduria. Now, again, a very important exam question. What is the first step in the management? The first step in the management for your CHPS, it is to correct the electrolyte imbalance. Correct the electrolyte imbalance. Now, फिर सवाल पूछ लेगा कि most important electrolyte to be corrected. Remember, the most important electrolyte to be corrected is chloride. Chloride correction के बाद ही करोगे. सर्जरी हमने already बात कर रखी है. That is Ramsted's pyloromyotomy. Now, same if you do a contrast imaging in the CHPS. CHPS में जब आप contrast imaging करोगे, this is going to give you a classical. Either we call it as a double track sign. You can call it as a double track sign, or you can also call it as the mushroom sign. You can also see the mushroom sign, but more importantly, look at how much amount of contrast is pooled inside the stomach per se. Okay? It is your stomach per se, right? Now this again is a very very important spotter. I hope everybody is able to pick it up. ये आपका diaphragm है. This is your liver that is present. और liver और diaphragm के बीच में there is free air that is there. So free gas under right hemidiaphragm. This is the X-ray for your pneumoperitoneum. Now this pneumoperitoneum is usually secondary to perforation. So this is an X-ray of a hollow viscous perforation. This is an X-ray of a hollow viscous perforation. And this tells you there is free gas under right hemidiaphragm. There is free gas under right hemidiaphragm. There is free gas under right hemidiaphragm. Okay. Same hollow viscous perforation when the gas becomes more larger. This is same. This is also the X-ray of a hollow viscous perforation. So what do you see? If it is a long standing, the patient is not getting treatment, the entire air is going to fill up. It looks like a football, no? It is also called as the football sign. It is also called as the dome sign. Now see, in an X-ray I can see air. So if the air is inside the bowel, I'll only see the air. But if the air is present inside the bowel and outside the bowel, I can see the wall of the bowel. And this wall of the bowel, if you are able to visualize, you can see that yellow sign that you have given. If you are able to see the wall of the bowel, you are able to line air andar hai, air bahar bhi hai. And this is what we call it as regular sign positive. So there will be presence of regular sign as well. So regular sign is able to demarcate the wall of the bowel. Okay. So this is seen in hollow viscous perforation. Now in this image I have given you A, B, C are the three components. Now what does A stands for? What does B stands for? What does C stands for? Now A is basically you're seeing there is stone. B tells you there is obstruction. C, there is air in the biliary system that is called as pneumobilia. So there is stone in the intestine, it is causing an obstruction and it is causing your pneumobilia. And this is a case of gallstone ileus. And now this gallstone ileus, no, ये जो तीन components are रखे हुए हैं, this is what we call it as the regular stride. This is what we call it as the regular stride. So there's an ectopic gallstones causing your small intestinal dynamic obstruction, and with that it is going to result in pneumobilia as well. Okay. Okay. Now this we have already dealt once. You see there is one bubble that is present. This is your gastric. This is your gastric bubble, and this happens to be your duodenal bubble. So this is your double bubble sign. This is your double bubble sign. Now, double bubble sign is seen in two conditions. One is going to be your duodenal atresia. Another one, it is going to be annular pancreas. Duodenal atresia and annular pancreas are two conditions where you will see double bubble sign. Now you see here, there's a step ladder pattern, multiple air fluid levels are there, and you can see the valvulae inconventi. So I know it is the jejunal obstruction that is occurred. Okay? And the ileum is not visualized at all. So it is multiple air fluid levels. Presence of multiple air fluid level. Presence of multiple air fluid level indicates intestinal obstruction. And it is central, no? So I can say it is small intestinal. So I say it is a small intestinal obstruction. So there is a step ladder pattern, presence of valvulae inconventi that can be seen. So it's a jejunal obstruction. So classical case of jejunal obstruction. It is a jejunal obstruction. Okay? This, everybody knows the Rapunzel syndrome, or also called as trichobazor, that is seen in trichotillomania. Now this is what we call it as thumbprint sign. Now this thumbprint sign is seen in ischemic colitis. It is seen in ischemic colitis. This thumbprint sign is what we call it as the ischemic colitis. So you can see all this mucosal edema, right? They represent as thumbprint sign. It is called as, this is what we call it as the ischemic colitis. On a CT, you can see this white black, and this is what we call it as the accordion sign. Where do you see accordion sign? Accordion sign kahan dekhne ko milega? Accordion sign will be seen in pseudomembranous colitis. It is seen in pseudomembranous colitis. Now here you can see the bowel is present in the left side, the mediastinal shift is there. This is your congenital diaphragmatic hernia, and this congenital diaphragmatic hernia is your Bosch-Dalek hernia. It is your Bosch-Dalek hernia. Okay. Now this is your apple core sign, and you can see hostration is there. So presence of apple core sign with the bowel hostrations indicates it is colon cancer. This is the colon cancer. Then you say this is the claw sign on an claw sign on a barium enema, and this is a classical for intussusception. This is classical for intussusception. It is classical for intussusception, right? Now here you see it is a technetium 99 scan. Technetium 99 has got a high affinity for gastric type of mucosa as well as transitional epithelium that is there in the bladder. Now, if there is presence of an ectopic uptake, indicates it is your Meckel's diverticulum. It is your Meckel's diverticulum, right? Now, Meckel's diverticulum, few important points. It is an example of a true diverticulum. It is an example of a true diverticulum. It is present on the anti-mesenteric border. It is present on the anti-mesenteric border. It is usually follows something called as the rule of 2. So it is, when you talk about it, it is going to be 2 inch in size. It is going to be 2 feet, which is approximately 60 centimeters, proximal to IC junction. Proximal to IC junction. It is seen in 2% of the population. So hence it is the most common congenital disorder of the intestine, and it has got 2 different mucosa. So one, it causes a gastric type of mucosa, and also consists of ectopic pancreatic tissue. Okay. So this is your classical coffee bean sign. Now the coffee bean sign, it is seen in sigmoid volvulus. See, I can see it is pointing towards the right upper abdomen. Okay. So this I know that it is a sigmoid volvulus. It is seen in the sigmoid volvulus. ठीक है, चलो. This is your barium enema. This is what we call as a bird of prey sign. So like a bird waiting to catch its prey. This is a bird of prey sign, and the bird of prey sign is seen in volvulus. It is seen in your volvulus, right? The bird of prey sign, it is seen in your volvulus, right? Now here you can see sawtooth appearance, the classical sawtooth appearance. This is seen in diverticulosis. This is seen in diverticulosis. You see a classical sawtooth here also, classical sawtooth appearance. So this is seen in diverticulosis. Absolutely correct. Okay. So this summarizes your entire GIT, right? So pura GIT, hepatobiliary, pancreas, all your radiographs, everything including the image-based questions are taken care of. Okay. So far any questions? Quick feedback? कोई सवाल, कोई शक? Any questions? Quick feedback? So now you have covered all the important topics. We have covered all the important images also. With that, we are able to club the entire information. So we are able to have this revision. This PDF, I will be sharing it right after the class. जब भी time मिले ना, एक बार just go through it and to do an, try to do an active recall also, right? In diverticulosis versus mesenteric ischemia की image में confusion है. But इसमें क्या है यार? Diverticulosis में you will see the entire lumen is clear, but you will see all these the pointy stuff will be there. तो ये देख रहे हो? विनोद, ये देखो, ये आप देख रहे हो, ये आपको मिलेगा. Whereas when you talk about mesenteric ischemia, आपको classical ऐसे मिलेगा. देखो, you see there is inward movement. वो बाहर की तरफ है, ये अंदर की तरफ है. ठीक है? बेटा हर्निया में अगर आज पढ़ाने के बाद अगर हर्निया में कंफ्यूजन हो रही ना, फिर तो दिक्कत है भाई. मतलब आई फील पर्सनली जिस तरीके से मैंने हर्निया पढ़ाया है, आई फील बिकॉज व्हेन आई रीड हर्निया एंड व्हेन आई गेट टू दैट द प्रिसिशन लेवल और द परफेक्शन, अगर आपको वो इमेज समझ में आया है, हर्निया कंफ्यूजन लाइक है ही नहीं. बट इफ यू आर नॉट वेल वर्स्ड विद दैट इमेज दैट आई हैव ड्रॉन और एनाटॉमिकली और नॉट ओरिएंटेड, फिर दिक्कत है. ठीक है? Can you move on? तो हम अपने रैपिड रिविजन के आखिरी पड़ाव पे. ठीक है? Meckel's diverticulum का मैनेजमेंट, इट इज गोइंग टू बी डाइवर्टिकुलेक्टमी विद प्राइमरी एनास्टमोसिस और द प्राइमरी क्लोजर. ठीक है? पहले बोलते थे कि कि वाइड माउथ, थिक बेस एंड ऑल दैट. नाउ इट इज इफ यू आर फाउंड इवन इंसिडेंटली, इट इज बेटर टू गो एंड ऑपरेट इट. ठीक है? चलो. So we have the last topic, which is going to be our urology. ठीक है? So we quickly talk about nephrolithiasis and then we'll build up our topics from thereafter. ठीक है? ठीक है? Once we are done, फिर बीच में पूछ लेना. Okay, guys, just okay, fine. We'll finish and then take a break because I'm getting a call from the hospital as well. Okay, we'll see as we move on. Okay, so let's talk about the nephrolithiasis, which are the kidney stones. When you talk about which is the most common kidney stone, remember the overall most common kidney stone is going to be calcium oxalate. Phosphate is considered to be the most radio-opaque. The most common radiolucent. The most common radiolucent is uric acid, and the hardest stone, that is a stone that cannot be broken down by ESWL, it is going to be a cystine stones. Now, calcium oxalate stone is because of hypercalcemia or hypercalciuria or hyperoxaluria. Phosphate stone is because of protease infection. Uric acid stone is because of conditions like gout where you have excessive uric acid secretion. Cystine stones is because of cystinuria, right? Characteristic feature when you talk about the calcium oxalate stones, they are round to oval. They are round to oval. They have sharp projection over their surface and they're dirty white. They are dirty white. When you talk about the phosphate stones, these are called as the triple stones. Now, why they're called as triple stone? Because they've got three components. Now, what are the three components? Magnesium, phosphate, and as well as you have the magnesium component, the ammonium component, as well as the phosphate component. Hence, it is called as triple stone. It is also called as the Staghorn calculi. It is called as the Staghorn calculi. It is also called as the struvite stone. It is also called as the struvite stone, right? So it is also referred to as the struvite stone. So Staghorn calculi, triple stone, struvite stone is your phosphate stone. Uric acid stones, on the other hand, they are formed in an acidic urine. They formed in acidic urine. So here you don't need to go and operate. If you convert the urine back to alkaline, the stones will disappear. So hence the drug of choice here is acetazolamide. Okay? Cystine stones, they are hard and they are black in color. So they are black and they are hard stones. So texture is going to be quite hard. Okay? So what is the radio status? These are radio opaque, this is radio opaque, this is radiolucent. Cystine consists of sulfur. It's a sulfur containing compound. So because of that, it is also radio opaque. Okay? Now when you look at the crystals, I have marked all of them. So when you talk about calcium oxalate, you will see envelope shaped crystals. So you will see an envelope shaped crystals like this. Phosphate, it will be coffin lid like crystals. Here you will have uric acid is your multi-faced. Cystine stones are hexagonal or hexagon, or also called as, it looks like a benzene ring, so it is also called as benzene shaped stones. It's a benzene ring shaped stone, so it is a benzene stone. Okay? So when you say in terms of investigation, you can do an ultrasound, X-ray, KUB, CT, urography. But if I say what is the investigation of choice, it is going to be CT, urography. The first investigation is going to be an X-ray, KUB. USG will tell you about the size of the stone. It will tell you the location of the stone. But more importantly, it will tell me the status of hydronephrosis. So it will tell me whether the hydronephrosis is formed or not. Now DMSA stands for dimercaptosuccinic acid. Now this DMSA, what is it used for? It is used to assess the morphology of the kidney. It is assessed to morphology of the kidney. It is going to look for the scarring in the kidney, and it is going to tell you about the anatomy of the kidney. So if you're looking for morphology, scarring and anatomy, I will go ahead with DMSA scan. Then you have that is DTPA, that is your DTPA stands for diethyl triamine pentaacetic acid. It is diethyl triamine pentaacetic acid. It is a pentaacetic acid. Now this is the investigation of choice for renal perfusion. This is the investigation of choice to assess for renal perfusion. MAG3 is your mercaptoacetyl triglycine. It is your mercaptoacetyl triglycine. Now when you talk about mercaptoacetyl triglycine, this is the gold standard. This is the gold standard for renal perfusion. This is the gold standard for renal perfusion. Okay? Now, how do you manage it? Based upon the size, less than 5 millimeters, it is going to be conservative. For 6 to 15, it is going to be ESWL. For more than 15, it is going to be PCNL. Staghorn, it is going to be ESWL with PCNL. Right? It is a sandwich technique that you're going to follow. Clear? Sufficient this session, sir, for 15 plus questions. See, guys, I'm not a person who is going to claim that, you know, you do this, you'll get 30 questions, 50 questions, 100 questions. Whatever we have covered, it is in a wholesome background. Okay? If you look at all those topics that we have covered, no question in surgery, I repeat, no question in surgery will be unanswerable. With this, you will have the confidence to approach it. There's a possibility you might get the same topic, same question, same formation, but if not, you will get the same structure. Okay? We have covered wide range of topics. We have done all 5 years of your topics as well. So this should give you enough amount of confidence to go kill it. फिर से बोल रहा हूँ, एक छोटा सा, just have a little bit of, what do you call this, as that inner feel, कि जो मैं पढ़ा रहा हूँ, I just want you to have a little bit faith in me, not more, a little bit faith कि जो मैं पढ़ा रहा हूँ, this is important, it would come in exam. It is the power of manifestation कि मैंने जो पढ़ा है वही एग्जाम में आएगा, मैंने जो पढ़ा है वही एग्जाम में आएगा, 10 बार बोलो वही होगा, ठीक है. लेकिन उसके लिए थोड़ा पढ़ना भी पड़ेगा ना, बस आंख बंद करके बोलो कि मैंने पढ़ा, पढ़ाई कुछ नहीं है तो आएगा क्या, ठीक है. तो पहले पढ़ लो, फिर मैनिफेस्ट करो कि जो पढ़ा है वही एग्जाम में आएगा, जो पढ़ा है वही एग्जाम में आएगा, वही आ जाएगा, और उसका आंसर कर लेना, खत्म बात, ठीक है. क्लियर है. See, in a staghorn calculi, you should do ESWL PCNL. It's a sandwich technique. Otherwise, open nephrostomy is what you have to do and extract the stone as well. Okay? Now, genitourinary tuberculosis, again, an important topic. In kidney, what do you find? Kidney में findings क्या क्या मिलेंगी? Number one, you are going to get something called as the cement kidney. Then you will get your putty kidney. And eventually it will go into autonephrectomy. You will go into autonephrectomy. Bladder mein you will see presence of golf hole ureter. You will see presence of golf hole ureter. Along with golf hole ureter, you are going to get thimble bladder. Thimble bladder is going to be fibrosed, condensed, and reduced bladder. So it is fibrosed, condensed, and reduced bladder. It is going to be fibrosed, condensed, and reduced bladder. Okay. So, in the prostate, you will get hard indurated prostate. Hard indurated prostate. Vas different, you'll get beaded vas difference. Scrotum, you'll get multiple discharging sinus. You'll get multiple discharging sinus. Okay? Yeah. So these are the important points with respect to genitourinary tuberculosis. This is in a nutshell that you should remember. Okay? So now, when you talk about benign prostatic hyperplasia, what is the basic pathophysiology behind it, BPH? I know you guys know most of it. I'll have a quick recap. BPH is an age-related phenomena. So as the age increases, you will now notice that the concentration of testosterone in the body is going to reduce, right? Now, the testosterone reduces because the testosterone gets converted into dihydroxytestosterone. It gets converted to dihydroxytestosterone with the help of an enzyme that is 5-alpha reductase enzyme. Okay? So with age, what is going to happen? The 5-alpha reductase enzyme is going to increase, and this will cause more and more conversion to dihydroxytestosterone, right? Now remember, this dihydroxytestosterone is the most potent stimulator of the prostatic tissue. Now this is the most potent stimulator. This is the most potent stimulator of prostate, right? So problem क्या है? जैसे age increase होगी, 5-alpha reductase enzymes are going to produce more. So more and more amount of testosterone gets converted into dihydroxytestosterone, and this dihydroxytestosterone is the most potent stimulator of the prostate gland. Hence, the prostatic tissue will start to proliferate. Problem is not that. The problem, you'll understand that this is the bladder, and the bladder wall has this muscle, and this muscle is what we call it as detrusor muscle. And it is the detrusor muscle that is going to contract for the bladder to evacuate the urine. And at the base of it, you have your prostatic gland. Now, in a patient of BPH, as there is dihydroxytestosterone is going to form, you will now notice the prostate gland is going to enlarge. Now, if the prostate gland is going to enlarge, it is going to compress the urethra. It will not allow the urine to evacuate out. So, what is going to happen? In order to overcome this compression, there will be a compensatory enlargement of the detrusor muscle. Now, as the detrusor muscle enlarges, it is now going to increase the force of contraction. And as it increases the force of contraction, the patient will be able to evacuate. Patient remains asymptomatic. But we all know that BPH is a progressive disorder. The prostate gland will continue to enlarge. And to compensate for this enlarged prostate gland, detrusor muscle says, I will not leave it. I will also enlarge. Now, as the detrusor muscle becomes very bulky, problem is bulky muscles can contract with greater force but cannot contract repeatedly. So here what is going to happen, as the compensation continue to occur, you will see the force of contraction will increase, but the rate of contraction is going to decrease. Now, as this happens, and if it occurs, if the rate significantly reduces and the force is there, so it's like contracts once and it takes longer time to relax, and the next contraction comes with further more time. So here the patient becomes symptomatic, and this is what we call it as detrusor instability. Now, when the patient will have detrusor instability, patient will now become symptomatic, and this detrusor instability symptoms is what we call it as BPH. So again, a very important concept here, the symptoms in BPH is not because of enlarged prostate gland, it is because of detrusor instability. Now, that is something that you have to keep in your mind. You cannot afford to forget it. Now, in a BPH, you should know which of the following is a voiding symptom, which is the following is a storage symptom. So you will see in a voiding symptom, there will be hesitance. Patient will not be able to start the stream. There will be poor stream. There will be intermittent stream. It will cause post-maturation dribbling, sense of poor bladder evacuation, and there will be episodes of retention. Frequency will increase. There will be presence of nocturia. There will be increased urgency. There will be urge incontinence and nocturnal incontinence called as enuresis. All these will follow as storage symptoms. Now, what are the complications? This is, you do a cystoscopy, you see these fibrous bands. This is what we call it as bladder trabeculation. There will be presence of bladder trabeculation, and if the pressure increases, it will now develop into a bladder diverticula. It will develop into a bladder diverticula, right? So when we talk about the investigation in BPH, now, what are the investigations that you can do? I can start the investigation by doing a digital rectal examination. I will see there is presence of an enlarged prostate gland. You see an enlarged prostate. You can also do an ultrasound. The ultrasound will also tell you there's an enlarged prostate, but the investigation of choice is going to be uroflowmetry. Now, as I told you, the BPH does not rely on the size of the prostate gland. It is the detrusor instability. So, on a uroflowmetry, you will see how functional the bladder is. If it is more than 15 ml per second, it is considered to be normal. If it is between 10 to 15 ml per second, it is considered to be equivocal. It is considered to be equivocal. And if it is less than 10 ml per second, it indicates of obstructive features. That is your bladder outlet obstruction. It tells you patient is having bladder outlet obstruction, probably because of BPH, right? PSA has to be done. Remember, the normal PSA value is less than 4 nanograms per deciliter. Now, in a cancer, it will be more than 20 nanograms per deciliter. Now, management for BPH initially will be medical management. The drug of choice is going to be alpha 1A blocker. That is going to be tamsulosin. You can also add, that is a 5-alpha reductase inhibitor, that is a fenestride. In fact, fenestride has a better effect than the alpha 1A inhibitor, but alpha 1A inhibitor is faster, so hence you will prefer tamsulosin over fenestride. Now, the surgery of choice is going to be TURP, that is a transurethral resection of prostate, and here the irrigating fluid of choice. The irrigating fluid of choice. For TURP, it is going to be 1.5% glycine. It is going to be 1.5% glycine. So this is how you do TURP. Before and after, you can see the component of the opening is created well. The urine flow is maintained. So hence, TURP becomes the surgery of choice. What are the contraindications for TURP? Now, currently the contraindications for TURP, if there are hip disorders, patient cannot be put into lithotomy position. If there is a hip disorder, if there is a bleeding disorder, It is better to do an open rather than doing a TURP because the control cannot be taken. Relative contraindications that you can have if the size is more than 100 cc and time taken is more than 90 minutes, then I would prefer an open surgery. Now, what are the open surgical options that you have? You have the Frey's technique, you have the Millen's technique, and you have the Young's surgery. All that you should know, Frey's is going to be a transvesical approach. It is your transvesical approach. Millen's is considered to be as retropubic approach, and Young's is considered to be the perineal approach. Young's is considered to be that of the perineal approach. It is the perineal approach, right? So you have the transvesical approach, you have the retropubic approach, and you have the perineal approach. All these are open surgeries. The latest one that you have is HOLIP, that is holmium laser induced prostatectomy. It is holmium laser prostatectomy. This is your holmium laser prostatectomy. Clear? Right? So this is with respect to your benign prostatic hyperplasia. Okay? Clear? Chale. We'll talk about the congenital disorders of the testes. We have two components, the undescending testes and the ectopic testes. Repeatedly asked exam question. So try to quickly summarize here. So when you talk about the undescending testes, sorry, one second. So when you talk about undescended and the ectopic testes, what is the most common site for the undescended testes? It is going to be a superficial inguinal pouch. It is your superficial inguinal pouch. Ectopic testes का जो most common site है, that is going to be the inguinal canal. So I'm saying ulta, sorry. Undescended testes का most common site is inguinal canal, sorry. It is the inguinal canal. Ectopic testes, it is going to be superficial inguinal pouch. Superficial inguinal pouch. ठीक है? मेरे से गलतियां मत करो, थोड़ा एक्टिव रहो, चैट बॉक्स में कुछ बोलो, पता तो चलना चाहिए कि लोग हैं, ठीक है? अनाउंस योरसेल्फ, यू आर देयर. रात के 12 बज रहे हैं, ठीक है, मालूम है मेहनत कर रहे हो, आपके साथ हम भी लगे तो ऐसे थोड़ा ना छोड़ देंगे. ठीक है, चलो. So what is status of the testes? It is in undescendant, it is poorly developed. Ectopic testes, it remains normal. Secondary sexual characters, if it is unilateral, they'll be present. If it is a bilateral undescendant testes, it will be lost. Here it remains normal. Spermatogenesis, it is going to be lost, I can say. In undescendant testes, spermatogenesis is normal. Scrotum is poorly developed. You can see it is planed out. There is no rugosities, whereas here scrotum is normal, right? So when you talk about, okay. Now when you talk about the investigation, remember the investigation of choice. Now, to be very honest, to diagnose it, it is clinical examination. But if they change the question, investigation of choice to localize. If you're not able to localize it, it is diagnostic laparoscopy is preferred over MRI. The diagnostic laparoscopy is preferred over MRI in both these contexts. As simple as that. Okay? So this is with respect to undescendant testes as well as ectopic testes. Okay? Now again, अच्छा एक protocol ले लेते हैं. How do you manage? So ectopic testes I'm not much worried about. For undescendant testes, how do you manage? The protocol for undescendant testes management. अगर bilateral होगा तो cryptorchidism बोलते हैं ना. So if it is, we'll see whether it is a unilateral undescendant testes or a bilateral undescendant testes. Unilateral undescendant testes, we'll see whether it is palpable or non-palpable. We'll see whether it is palpable or whether it is non-palpable. Whether it is palpable or whether it is non-palpable. Now, if it is palpable, go bring the testes and put it back here. So that is going to be orchidopexy should be performed. Now, if it is a non-palpable testes, then you will take the patient for diagnostic laparoscopy. You take the patient for diagnostic laparoscopy. in the diagnostic laparoscopy, I can encounter two things. There will be presence of intra-abdominal testes, or there could be a blind ending vessel, or there could be no testes, right? So here you can have, number one, presence of an abdominal testes. There could be a blind ending vessel, and there could be no evidence of testes. If it's an abdominal testes, you have to bring it back and do an orchidopexy. If there is a shorter vessel, you can do a staged procedure, and for that is what we call as the Fowler-Stephen surgery. This is what we call as the Fowler-Stephen surgery. Blind ending vessel indicates that it is monoorchia, that is single testis. No testis also indicates it is monoorchia. The baby is born with single testes, right? Now my problem starts when you have a patient with bilateral undescendant testes. I should know whether this baby is a male or a female. Okay? For that, what are you going to do? We are going to give injections of beta HCG. Now we'll see after giving this, is there presence of response or absence of response? Presence of response. That means you'll see, when I say presence of response, there's increased FH, there's increased, that is FSH, LH. There's increase in luteinizing hormone as well as FSH. So that indicates the baby has testes. I'll take the patient for diagnostic laparoscopy. If there is no response, then I will say the baby is having anorchia. There is no test. Then you have to go with sex determination. Then you have to go ahead with sex determination. ठीक है? तो आज के डेट में ना आपके एग्जाम के लिए ये 5 सितारे. ठीक है? चलो गाइज, जैसे ये खत्म हो जाएगा ना रैपिड रिवीजन, इसका ये मतलब नहीं है कि मैं आपका साथ छोड़ दूंगा. ठीक है? वी हैव आवर टेलीग्राम ग्रुप जो अपना मेडेड का है. यू कैन कीप पोस्टिंग क्वेश्चंस देयर. एक काम करेंगे, आई विल कम एवरी डे एटलीस्ट वंस टिल द एग्जाम डेट, और एक टॉपिक मैं आपको वहाँ पे पढ़ा दूंगा जो आपको लगता है कि आपका क्लियर नहीं है. ठीक है? तो वहाँ पे आप मुझसे 1-on-1 क्वेश्चन पूछ सकते हो, सो दैट आई कैन एक्सप्लेन यू. अगर कुछ लगा तो वो भी बता देंगे, कोई टेंशन नहीं है. ठीक है? सो अभी डोंट ट्राई टू ओवर बर्डन योर सेल्फ. ठीक है? या टेलीग्राम में विल डू Q&A सो दैट एवरीबडी स्टिल इंटैक्ट. पकड़ के चलेंगे एग्जाम तक, डोंट वरी अबाउट इट. ठीक है? चलो, तो अभी के लिए विल फोकस ऑन व्हाट वी हैव इन आवर हैंड एंड देन विल ट्राई टू मूव अक्रॉस दैट. चल रहे आगे. कैन यू मूव ऑन? चलो. So we have few images which are usually asked. The first one is your Fournier's gangrene. The Fournier's gangrene is what we call it as the necrotizing fasciitis of the perineal region. It is the necrotizing fasciitis of the perineal region. It is the necrotizing fasciitis of the perineal region. It is an example of a synergistic gangrene. It is an example of a synergistic gangrene which is going to have both aerobic as well as anaerobic bacteria. There will be aerobic as well as anaerobic bacteria which is going to be involved. Okay? Now, it is usually associated with risk factors like diabetes and immunocompromised status. And diabetes as well as immunocompromised. So here it is going to, the investigation of choice is going to be a clinical examination. Management is going to be cleaning and debridement. And remember here, it will have testes sparing. It is going to eat away all the scrotum. So hence it is also called as, this disorder is also called as shameless testes. Right? So scrotal wall goes away, only the testes are visualized. So it is called as shameless testes. Okay? Chalo. So in the radiographs, what is the first image? This is what we call it as the horseshoe kidney. This is your horseshoe kidney. So in this horseshoe kidney, This is your flower vase appearance. This is your flower vase appearance. So when it comes down to horseshoe kidney, no. In a horseshoe kidney, what is the disorder? It is combination of anomaly of fusion. अब ये जो anomaly of fusion है, the most common site, it is going to be between L3 as well as L4, ठीक है, with anomaly of ascent. The anomaly of ascent, that means it is not able to move upwards. So the anomaly of ascent, it fails to move up, or the anomaly of ascent is due to inferior mesenteric artery. So it is inferior mesenteric artery which prevents its ascent. Okay? Now this is a classical image of your Staghorn caliculi. We have discussed in detail, so nothing more about it. This is what we call it as the putty kidney. Now this is also in tubercular, we have discussed it. So this is how the putty kidney's image would look like. Now this is what we call it as, you can see a fish hook ureter. So this is what we call it as the fish hook. The fish hook ureter is seen in retrocaval ureter. So ureter is going to go around the IVC, right? Now those who are not able to comprehend, you will notice if this is the kidney which is present, right? And this is the inferior vena cava which is running here. Let's say this is the IVC which is running here, right? You see the ureter that is going to arise from here. This is the pelvic ulcer system. Normally it should override from here, but if the ureter goes behind the IVC and then it comes like this. If it goes behind the IVC and then it comes like this, this is what we call it as the retrocaval ureter. Now what is happening? It can get compressed. The ureter can get compressed, the patient can have hydronephrosis. This is your retrocaval ureter. This is a soap bubble sign. Where would you see a soap bubble sign? The soap bubble sign is seen in hydronephrosis. It is seen in hydronephrosis. It is seen in your hydronephrosis. Okay? The last one that you have is your spider leg appearance. This is seen in polycystic kidney disease. It is seen in polycystic kidney disease. Adult, it is autosomal dominant. Child, it is autosomal recessive. It will have bilateral involvement. It is associated with end-stage renal disease. What is the surgery for polycystic kidney disease? The surgery that is available is your Rovsing surgery, which is cyst deroofing. But if I say what is the treatment of choice, the treatment of choice for polycystic kidney disease is going to be renal transplantation. It is going to be renal transplantation. Okay? So this is all in all that you should know in the context of urology as well. So with this, we conclude our discussion on your entire component that is going to be your rapid revision series. Okay? Before we move on, okay, so if you want, you know our MedEd channel is there. Everything will be available down there, so don't worry about it. So before we wrap it up, couple of important things that I would want to talk to you. ठीक है, 2 मिनट माहौल बना लेते हैं. कोई सवाल कोई शक है तो बता देना. इसको थोड़ा साइड कर लेते हैं. इसका काम हो गया. ठीक है. Okay, so every single guy who is watching right now, क्या करना है क्या नहीं करना है इन 15 दिनों में. I would not tell you in a very negative connotation, लेकिन एक बात है कि अगले 15 दिन, ठीक है, you have to make most of it. जितना अपना टाइम हमारे पास है हम पूरी जान लगाएंगे. दिन में 16 घंटे 18 घंटे जितने दे सकते हैं we'll give to our books and we'll stay true to our preparation. इन 15 दिनों में नोट्स पकड़ के नहीं बैठना है. You have to stick to your revision material. That अगर आपने पहले बनाया that is good, otherwise you're listening. अगर अभी बनाया that is also fine, but stick to one source material. दूसरा, अभी बैठ के हम पढ़ाई नहीं करेंगे, हम क्वेश्चंस करेंगे. दिन के 200 सवाल सॉल्व करने हैं, उससे कम में बात नहीं बनेगी. 2 GT देने हैं, मैं फिर से बोल रहा हूँ 2 GT देने हैं. Every single day when you give questions or when you start doing questions, make sure you attempt it like a real exam. ठीक है, you start making that effort from today itself. cut out all these stupid noises. Do not listen to your friends or any other guy who's trying to give you an advice. Right now, it is not worth it. All that it is worth is to have your own focus, believe in your preparation, have a little bit of faith in yourself. Every day morning when you get up, go walk to that mirror, look into that mirror and talk to the person you're looking at. Tell that person that you have done well, you have been doing well, you have been working hard, and you will get what you deserve, and then go back and start reading. The best thing to do is starting in the morning, you do your 50 MCQs, then read whatever you want to do, again do 50 MCQs in the afternoon, then start reading. देखो आफ्टरनून लंच के बाद सबसे ड्राउजी पीरियड होता है, तो डू क्वेश्चन सो दैट यू रिमेन इंटरेस्टेड, थोड़ा वो इंटरेस्ट बना रहे, एंड देन इवनिंग यू स्टार्ट रीडिंग. रात को सोने से पहले 50 क्वेश्चन, ठीक है. Once you start doing it, see, you have two set of students जिन्हें all 19 subjects पढ़े होंगे और those who are not able to finish all 19 subjects. Right now, it is not the time to read of what you have left. जो सब्जेक्ट छूट गए हैं उसको अभी बैठ के नहीं पढ़ना है. उसके लिए the smartest way to do is to finish your 5 years of your PYQs. Let's say you have कोई छोटा सब्जेक्ट आपने नहीं पढ़ा है. मान लीजिए कि आपने you have not read psychiatry or you have not read ortho, you have not read anesthesia. All that you have to do is previous year के questions उठाने हैं, make sure you get oriented to those questions and खत्म, ठीक है. उससे ज़्यादा एफर्ट नहीं मारना है. लेकिन जो आपके स्ट्रॉन्ग सब्जेक्ट्स हैं उनको रिवाइज इतने अच्छे से करना है ताकि यू आर एबल टू कॉम्पनसेट इट. अब एग्जाम में कुछ ट्रिक्स हैं, ठीक है. दैट हाउ डू यू कम, लेट्स से यू गॉट अ बाउंसर. मान लो ऐसा कोई क्वेश्चन आए कि कभी सुना ही नहीं है. पर मान लो मैंने आपको क्वेश्चन दिया ब्रिज हॉक सिंड्रोम पे, ठीक है, सुना ही नहीं होगा, ठीक है. अब ब्रिज हॉक सिंड्रोम में आपको क्या मिलेगा? यू गेट सीपैम मिलता है, दैट इज कॉन्जेनाइटल पल्मोनरी एयरवे मालफॉर्मेशन, कभी सुना ही नहीं है. तो अब क्या है, ऐसे सवाल में ना द एग्जामिनर इज ऑल्सो स्लाइटली कर्टियस टुवर्ड्स यू, वो आपके बारे में सोचता है. तो जब ऐसा कोई क्वेश्चन देगा which is not probably like a bouncer, उनकी ऑप्शंस देख लेना. जो आपको मोस्ट फेमिलियर ऑप्शन लगेगा, तुक्का कैसे मारना उसका भी ट्रिक है, ठीक है. क्वेश्चन पढ़ा, एलिनेटेड ऑप्शन क्वेश्चन है, मतलब टॉपिक समझ में ही नहीं आ रहा, कभी देखा ही नहीं, कभी सुना नहीं, लेकिन अगर उसका ऑप्शन अगर आप पढ़ोगे और जो ऑप्शन आपको मोस्ट हर्ड लगेगा, जो मोस्ट ऐसा कोई हो ही नहीं सकता कि आपने कभी पढ़ाना और एग्जाम में आ जाए, ठीक है. तो जो मोस्ट हर्ड ऑप्शन होगा दैट विल बी योर आंसर. दैट इज वन ट्रिक. Second, whenever you have a question where you are stuck within two options, ठीक है, तो मान लो कि आपने 2 एलिमिनेट कर लिए और 2 बच गए. अब 2 बचों में से कैसे चूज करोगे? रीड द क्वेश्चन अगेन, read the question again, don't think about the option, and then try to say that particular option sits into that particular question or not. तो जो फर्स्ट आएगा, 2 ऑप्शन में कंफ्यूजन है, क्वेश्चन वापस पढ़ेंगे एंड देन क्लोज योर आइज एंड व्हाटएवर यू फील दैट विल बी योर आंसर. हमेशा फर्स्ट इंस्टिंक्ट में जो आंसर लगता है वो सही होता है, बाद में जाके चेंज नहीं करना. प्लीज डू नॉट डू दैट. whenever you are reading a question, again as I told you, अगर ओपनिंग में ही बड़ा क्वेश्चन है स्किप कर दो. इट इज नॉट वर्थ, बिकॉज दैट इज ट्राइंग टू टेस्ट योर पेशेंस. अभी हमारे पास मोमेंटम बनाना है, पेशेंस हमारे पास बाद में आएगा. जब आपको पता है कि आपने 50 क्वेश्चन का जो स्लॉट है उसमें से 40 कर लिए हैं, आपके पास 10-15 मिनट और बचे हैं, दैट गिव्स यू अ लॉट ऑफ कॉन्फिडेंस. यू कैन गो बैक एंड रीडू दोस क्वेश्चंस. तो पहले बड़े क्वेश्चंस नहीं अटेम्प्ट करना है, कीप स्किपिंग इट. देयर विल बी अ फेज वेयर यू गेन मोमेंटम, यू स्टार्ट पॉइंटिंग आउट ऑल द आंसर्स एंड ऑल द क्वेश्चंस करेक्ट, एंड दैट इज व्हेन यू नो दैट यू हैव गॉन केन. देखो जब 10 क्वेश्चंस एक साथ सही होने लगते हैं ना, एकदम टक 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 सही होने लगेंगे, देन यू विल रियलाइज कि वो अपने आप से ना वो पॉजिटिव एनर्जी आती है, एंड जो याद नहीं भी है ना वो भी याद आने लगता है. तो योर सबकॉन्शियस मेमोरी गेट्स स्टिमुलेटेड. द बेस्ट वे टू स्टिमुलेट योर सबकॉन्शियस मेमोरी इज टू स्टे हैप्पी. एग्जाम में कैसे हैप्पी रहोगे? when you get multiple questions correct. तो वो सही questions की लड़ी, that streak of right questions you have to find, ठीक है. Another thing is do not panic. होता ये है कि first question देखा नहीं आया, second question देखा नहीं आया, third question देखा नहीं आया, fourth question देखा नहीं आया, 5-6 questions जब नहीं आते ना तो फट जाती. Then you feel okay, probably the exam is tough. Exam is no. Whatever was tough, it is already presented to you. इसके बाद सब आसान है, ठीक है. If you have not done one session well, do not carry forward that mindset to the next session. ठीक है, जो next slot होगा, start fresh. Make sure you are practicing those sessions and slottings also, so that you have that good feel of the exam, right? Once you are approaching the day of the exam, the last 48 hours is very important. In last 48 hours, you have to make sure, how do you gain confidence? ठीक है, ये दिल ना, इसको थोड़ा बुद्धू बना के रखना जरूरी है, ठीक है. तो कैसे बुद्धू बनाओगे? How will you fool your heart by telling that everything is normal? कैसे करोगे? In last 48 hours, यू हैव टू डू ओनली PYQs ऑफ लास्ट 3 सेशंस और कुछ नहीं करना, ठीक है। मेडिसिन उठाओ, PYQs करो 3 सेशन के, सारा कॉन्फिडेंस मिलेगा। सर्जरी उठाओ, ऑप्शन गाइनी उठाओ, पीडियाट्रिक्स उठाओ, करते रहो 48 आवर्स में आपके 2 दिन में आपने सिर्फ यही करना है। और जो भी आपने छोटे छोटे टेबल्स बनाए होंगे ना जो पढ़ने के लिए, उसको बीच बीच में रिवाइज कर लेना। दिस इज हाउ यू विल गेन कॉन्फिडेंस। ये बताएगा कि दिल को कि देख तूने सारे 19 सब्जेक्ट्स पढ़ रखे हैं, सारे 19 सब्जेक्ट रिवाइज कर रखे हैं, यू हैव रेड एवरी सिंगल क्वेश्चन, एवरी सिंगल टॉपिक इज नोन टू यू। एग्जाम में ऐसा कोई क्वेश्चन आएगा ही नहीं कि जो मेरे को पता नहीं है, ठीक है। दैट कॉन्फिडेंस विल डू अ वर्ल्ड ऑफ डिफरेंस इन द एग्जाम। ऑन द डे ऑफ एग्जाम खाना खाने का, सुबह उठने का, ठीक है, वो एंग्जाइटी होती है। एंग्जाइटी में क्या होता है, एपिनेफ्रिन, नॉरएपिनेफ्रिन, ऑल दैट, यू नो, देयर इज अ स्टॉर्म दैट अकर्स, इट कॉजेज वेसोकंस्ट्रिक्शन। वेसोकंस्ट्रिक्शन से ब्लड सप्लाई टू द गट डिक्रीजेस, तो खाना खाने का मन नहीं करता। तो सबसे पहले उठ के अपने आप को बोलने का ऑल इज वेल, ठीक है। फिर ठूसने का। खाली पेट कोई जंग जीती नहीं जाती, राइट। एम्प्टी स्टमक विल ओनली कॉज मोर प्रॉब्लम्स। तो खाना खाने का, मस्त खाने का, कोई पहले से डिसाइड कर लो ना, स्विगी जोमेटो से क्या ऑर्डर करना है पहले ही रख लो, ऑर्डर दैट। और घर पे हो आराम से मम्मी को बोलना अच्छा खाना बनाने का, सुबह जल्दी उठने का, खाना खाने का, टेंशन नहीं लेगा, किताब छूने का ही नहीं। डोंट इवन टच द बुक, डोंट इवन टच द नोट्स, नथिंग। वो टेबल्स, वो छोटे छोटे, नथिंग। गो विद दैट पीसफुल माइंड। अगर आपको लग रहा है, इफ देयर आर सर्टेन पीपल हु फील बेटर बाय डूइंग दैट थिंग, तो कीप सम फॉर्म ऑफ अ टेबल जो आप टक 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 जल्दी देख लो, ठीक है। एंड वंस यू डू दैट, गो फॉर द एग्जाम, ठीक है। बेटा GT 11th को मत दो, 11th वाला दिन खराब हो जाएगा। द बेस्ट डे टू गिव अ GT विल बी 8th of January और 9th of January। उसके बाद आपके 3 दिन रहेंगे टू रीग्रुप एंड रीकूप। अगर आपको कुछ देखो, GT का स्कोर देख के डरना नहीं है। जो GT का स्कोर है ना, दैट इज ओनली ट्राइंग टू टेल यू, देखो GT जो डिजाइन किए होते हैं वो अपने के एग्जाम से एक्चुअली 2 लेवल ऊपर ही होता है। तो अगर GT में आपके 120 130 आ रहे हैं, एग्जाम में 150 160 आएगा। दैट्स हाउ से 30 40 का मार्जिन है। अगर GT में 200 आ रहा है तो आप एग्जाम में 230 220 का, मतलब यू विल अचीव दैट 200 प्लस, ठीक है। तो डोंट डिसहार्टन बाय GTs। तो आइडियल टाइम टू गिव GTs विल बी 8th और 9th के बीच में, दैट विल बी द बेस्ट टाइम टू गिव GTs, ठीक है। तो दिस इज ऑल दैट आई हैव फ्रॉम माय एंड. I hope I was able to provide you a little bit of perspective. I wish you all the best from, you know, all the MedEd team, and especially from my side, from the bottom of my heart. I root for you. I want you to win this battle. I want you to go to the end. और exam खत्म होने के बाद आके बताना कैसे था, ठीक है? And I'm pretty sure everybody who's working hard, it is not going to be unnoticed. All those बच्चास who had last session 140 plus, इस बार 210 plus आना चाहिए, ठीक है। और वो आएगा टू कीप योर माइंड कूल एंड काम। याद रखना वो वाला ट्रिक, दिल को थोड़ा सा बुद्धू बना के रखने का। एंग्जाइटी में अच्छों की लग जाती है, ठीक है। एंग्जाइटी में अभी बताया था वेजो कंस्ट्रक्शन होता है, ब्लड सप्लाई टू द ब्रेन विल आल्सो डिक्रीज, तो आंसर आएगा ही नहीं, ठीक है। टू कीप एवरीथिंग दैट अवे, मेक श्योर यू आर फोकस्ड एंड स्टे कूल एंड काम। ऊपर वाला माला खाली रखने का, इधर को बुद्धू बना के रखने का, बाकी अपने आप टेंशन फ्री रहेगा, ठीक है। सर्जरी के लिए जो मैंने पढ़ाया है, इट इज मोर देन इनफ। इक्का दुक्का प्लस माइनस हो जाएगा, बाउंसर आप मार ही लोगे, टेंशन नहीं है। तू नहीं आंसर करेगा तो कोई आंसर नहीं करेगा। FMGE में बाउंसर एक्चुअली 10 से 15% ही होते हैं। मोस्ट ऑफ द क्वेश्चंस आर रीपैकेज्ड एंड वी हैव ट्राई टू प्रेजेंट इट इन आवर ओन वे। थोड़ा एफर्ट एक्स्ट्रा लगेगा, लेकिन लगा लेना। 200 क्वेश्चंस पर डे, 2 GTs बिफोर द एग्जाम, डू नॉट फॉरगेट दैट, ठीक है बेटा। ऑल दोस किड्स, यू नो, जो 140 to 150 के 149 के बीच में है ना, they deserve to pass. I'll be very honest, they really deserve to pass. The only thing was वो दिन अपना था नहीं, ठीक है। जिस दिन एग्जाम था, काश दिमाग की बत्ती और 2-3 खुल जाती, एक आधा सवाल और सही हो जाता, तो आज लाइन के उस पार होते। तो डोंट बीट योरसेल्फ अप। द डे वाज बैड, उस दिन प्रॉब्ली यू आर एंशियस, दिमाग बहुत टेंशन में था, दिल बहुत डरा हुआ था, तो एग्जाम में लग गई, ठीक है। सो आई वॉन्ट यू टू गो विथ एन ओपन फ्रेम ऑफ माइंड, स्टे कूल, स्टे काम, आराम से देना। इस बार वो 140 से 150 का जो डिफरेंस है ना, वो सिर्फ इधर वाले माले की वजह से है, ठीक है, कि इतने एंशियस, इतने डरे हुए थे कि वो 10 सवाल इधर उधर हो गए, अदरवाइज वुड हैव पास, ठीक है। सो डोंट वरी अबाउट इट, मेक श्योर स्टे स्ट्रॉन्ग, मेक श्योर डू नॉट लिसन टू एनीबडी, स्टिक टू वन सिंगल मटेरियल। फिर रिपीट कर रहा हूँ, 200 सवाल पर डे, 2 GTs बिफोर द एग्जाम, राइट। With that, you will nail the exam to the core. ठीक है. With that, thank you so much for listening. रात के 12 बज रहे हैं. I have odd 50 odd students who are sitting live. Hats off to your dedication, and this is what will make you a different person from the rest of the crowd. Before I close, summarize करने से पहले एक छोटा सा कहानी बताना चाहूँगा, ठीक है. I'll just tell you a little bit of small story before we close it down. बेटा मेडिसिन बची हुई है, संतोष सर विल टेक केयर ऑफ इट, डोंट वरी अबाउट इट. पढ़ा है ओके, नहीं पढ़ा है तो जो रिवीजन में मटेरियल आएगा उसको अच्छे से रिवाइज कर लेना. 3 सेशंस के एमसीक्यूज करके जाना, इससे ज़्यादा कुछ और ज़रूरत नहीं होगी, ठीक है. बिफोर आई समराइज, आई जस्ट ट्राई टू एक्सप्लेन यू व्हाट इज दिस ऑल कॉम्पिटिटिव एग्जाम इज ऑल अबाउट, ठीक है. तो दिस हैपेंड विथ मी ओनली. आई वाज टेकिंग अ लेक्चर. I think it was a jam-packed hall. Around 1200 students were sitting. Okay? At the end of my lecture, I said, I need one person to come onto the stage because I want to demonstrate something. जैसे ही मैंने ये बोला ना, I want 1%. 1200 बच्चे थे. 1200 बच्चों के when I said I want 1% to be on dais, every single student had an equal opportunity to come down to the dais. लेकिन कोई उठा नहीं. ठीक है, प्रॉब्ली शाइनेस है, पीपल आर कंजर्वेटिव और दे आर लाइक ठीक है वाई शुड आई के चक्कर में नहीं हुआ. आई रिपीटेड अगेन कि आई नीड 1% टू बी ऑन डायस. कोई नहीं आया. तीसरी बार बोला, चौथी बार जब मैंने बोला ना तो 5-6 बच्चों को लगा यार बेचारा इतना बोल रहा था, एक आधा चल लेता. तो फर्स्ट रो से 1-2 बच्चा उठा, लास्ट रो से 1-2 बच्चा उठा, बीच रो से 1-2 बच्चा उठा. दे स्टार्टेड वॉकिंग टुवर्ड्स द डायस. नाउ एज दे वर वॉकिंग टुवर्ड्स द डायस, नो उन 10 बच्चों में से ना कुछ लोगों ने अपने आप को देखा एक दूसरे को कि वो भी चल रहा है मैं भी चल रहा हूँ, तो ठीक है वो पहुंच जाएगा, मैं क्यों चलूँ, तो बैठ गया. ठीक है. सो दे लुक्ड एट ईच अदर एंड दे सेड ओके दिस गाइज गोना रीच आउट एंड ही इज यू नो मेरे से आगे है तो व्हाई शुड आई ट्राई, एंड ही सैट. बाय द टाइम यू नो पीपल वर अप्रोचिंग द डायस, ओनली 2 या 3 बच्चे थे. देन आई फाइनली व्हाट आई सी इज एक बच्चा लेफ्ट से चढ़ रहा है, एक बच्चा राइट से चढ़ रहा है, बाकी सब बैठ गए. एट द एंड द गाय वाज यू नो स्टार्टेड फ्रॉम लेफ्ट, कंटिन्यू टू वॉक, राइट वाला रुक गया, वो चला गया और लेफ्ट वाला डायस पे आया. I just told him, thank you so much, you are an amazing guy, keep doing it, and I sent him back. तो everybody like क्या सर अभी तो कुछ डेमोन्स्ट्रेट करने वाला, तो क्या हो गया. इस पूरी कहानी में ना एक बहुत सिंपल सा लॉजिक छुपा हुआ है. लाइफ जब आपको अपॉर्चुनिटी देती है, सबको इक्वल अपॉर्चुनिटी देती है. एवरी सिंगल ऑफ यू इज सर्व्ड विद सिमिलर अमाउंट ऑफ अपॉर्चुनिटी. तो जब मैंने बुलाया उन 1200 बच्चों को ना, हर किसी को सेम अपॉर्चुनिटी टू कम डाउन टू डायस. लेकिन ओरिजिनली कितने लोग एफर्ट मारते हैं? 1%. 1200 का 1% भी ना 120 बनता है. ठीक है, और आगे से 12 बनता है इन दैट कॉन्टेक्स्ट. ओनली 1% ऑफ देम आर एक्चुअली ट्रूली सीरियस, और वही क्राउड है. और वह 12% लोग ना एफर्ट डालते रहते. उस 12% वो तो 1% जो ना 12 लोग में होता, वो 1% में से ओनली 1 ऑफ देम कंटिन्यूज टू पुट एफर्ट टिल द एंड, एंड दैट इज द गाय हु इज गोइंग टू विन. तो भीड़ देख के डरना नहीं है कि इतने सारे लोग हैं प्रिपेयर कर रहे हैं, मेरा क्या होगा. ना, तूने शुरू करना है, और जब शुरू किया है तो आखिर तक रुकना नहीं है. एंड दिस इज ऑल अबाउट कॉम्पिटिशन. So do not worry about what people are saying around you, what people are doing around you. You need to be consistent till the last minute. जब तक आपका एग्जाम का डे, to the day of the exam you have not finished your question paper, तब तक रुकना नहीं है. ठीक है. So keep that in mind. Continue working hard, and I'm pretty sure you are the one who is the most deserving to pass. ठीक है. एंड मेक श्योर यू डू सो, एंड विल सी यू ऑन द अदर एंड ऑफ द स्टोरी. एग्जाम के बाद इंटरव्यूज भी हैं तो बहुत बातें करेंगे. विद दैट थैंक यू सो मच, गुड नाइट, टेक केयर. बेटा जीटी में 130 से 150 के बीच में अगर स्कोर आ रहा है, उससे ज्यादा आ रहा है, यू आर डूइंग गुड, एंड दैट शुड बी योर टारगेट. ठीक है. विद दैट लॉर्ड्स एंड लॉर्ड्स ऑफ लव, थैंक यू सो मच, टेक केयर, गुड नाइट. इफ यू हैव एनी क्वेश्चंस, एनी क्वायरीज, यू कैन रीच आउट ऑन द टेलीग्राम. इसके बाद कल से हम I'll try my best to come every day on the Telegram group so that I can have some amount of discussion with you guys. Stick at MedEd. We'll see you there. Thank you so much. Good night.